Good day, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation of the series that we have started, What Surgeons Should Know, and it's about intestinal obstruction. And as a brief introduction to this lecture, actually, after reviewing many literatures discussing intestinal obstruction, I conclude that intestinal obstruction actually, it's a little bit hard to discuss it as a unique entity because finally this will lead you to the definitive diagnosis such as cancers, adhesions, pseudo obstruction, and these are different entities. These are separate lectures. So, what we are going to do today is discussing or reviewing the hotkeys, the common information in intestinal obstruction. Um, Also, many literatures include or highlight the volvulus and adhesions in this lecture. So we are going to talk in details about, for example, volvulus for pseudo obstruction and pseudo obstruction, volvulus. I think there is another entity and adhesions. We are also going to discuss it. Some causes of intestinal obstruction already we discussed it, such as those in the pediatric age group. We will see it in the next few minutes, and other will be discussed later in a separate lectures. Actually, in this lecture, again, we are going to talk about, for example, the classifications of intestinal obstructions, the pathophysiology. Also, we are going to talk about the clinical features, investigations required to diagnose intestinal obstructions, the management, and as we said, some special entities or special considerations, we call them. Okay. Okay. Actually, if we are talking about the classifications, there are many classifications. One of the most common classifications is that which depend on the etiology, and actually, as you see, they are divided. I, we call them classification number one. They are divided to dynamic and adynamic. Actually, dynamic, it's mechanical. You can see it as a mechanical blockage. To be clear in your mind, you can imagine cancer blockage. So it's dynamic obstruction and adynamic obstruction. That there are two scenarios in the adynamic. The first one, that the peristalsis is absent, for example, paralytic ileus, or it's present but not enough, non-propulsive form, such as in pseudo obstruction or mesenteric vascular occlusion. Again, to be clear, you can imagine dynamic like cancer, there is a blockage. Adynamic, it's actually, we are talking about paralytic ileus, we are talking about pseudo obstruction. So you can see here a picture. I found it in one of the literatures. They classify it to dynamic and adynamic. This is dynamic, this is adynamic. Let me check that the lecture is recorded. Yes. Okay. Dynamic and adynamic. And actually, dynamic, we said that there is a mechanical blockage. So, where is the mechanical blockage? The mechanical blockage can be in the lumen of the intestine, in the lumen of the intestine. We will see some examples, or in the wall itself, or outside compression, doing compression on the bowel. So they are called mural, intramural. You can see here. Out dynamic can be classified to outside the bowel. An example, a clear example is adhesion. One of the example of an extraluminal causes, sometimes we call it hernias, adhesion, volvulus, intussusception. These are causes outside the bowel. Um, Examples of actually intussusception can be we can consider it as luminal or in the bowel wall. It's different literatures actually. In the wall, for example, is the structure. Whatever, either tuberculous structure, Crohn's structures, ischemic structures, malignancies, they arise from the wall. So they are in the wall. Sometimes they call it intraluminal. And in the lumen itself, for examples, gallstone ileus, it's in the lumen. The stone is impacted in the lumen. Worms, whether either round worms or they call feces. We know that one of the causes is stercoral ulcer. It's when a feces is impacted in the lumen. And meconium ileus. These are causes in the side the bowel wall. You can't to imagine what I mean. You can see this picture. Actually, let me do zoom in. This is extraluminal. We call it outside. Extraluminal, it's when compression outside the bowel wall. For example, adhesions, band, hernia. Neoplasm, they mean neoplasm outside the bowel wall, outside from other origin. And abscesses. Intraluminal, intraluminal, something inside the bowel wall. For example, gallstone ileus, worms, bezoars, and foreign bodies. These are intraluminal. And causes the causes intrinsic to the bowel wall. It's another in another word in the bowel wall itself. For example, tuberculosis, intussusceptions, Crohn's, endometriosis, neoplasm, cancers, malrotations. I know that some of you will say that intussusception, for example, here are divided under the term outside here in the bowel wall. It's different literature, doesn't make a big deal. And adynamic causes, we said it's mean non-mechanical causes. And examples of intestinal obstruction that can be adynamic, for examples, this is a general term, cessation of peristalsis. Why? Cessation of peristalsis. Post-operative, we know post-operative ileus is a respective entity, and electrolyte imbalance, we know hypokalemia, for example, hyponatremia also can be causative. Spinal injuries, uremia, some uremia actually leads mainly to an entity called spastic ileus. Spastic ileus actually it's extreme contraction and then fatigue, then peristalsis, hyperactive peristalsis, and finally aperistaltic period, puremia. Diabetes mellitus, for example, we know diabetic gastropathy, delayed the transition of food. Retroperitoneal causes, extremely important, for example, hematomas or surgeries, kidney surgeries, for example, renal surgeries, mesenteric ischemia, one of the adynamic causes, and pseudo obstruction. Pseudo obstruction will be discussed later in this lecture in details. So this is one of the most important classifications. Let's move to another classifications. They say classification number 2, which depends on the type of obstruction. Actually, here the acuity of the obstruction. The obstruction can be acute, as you see, can be chronic, acute on chronic, subacute, and closed loop. Some literature said that closed loop under this classification, other included in another classification, but doesn't matter. The matter is the information. Acute, actually, what I want you to remember, acute, it's severe sudden colicky, severe colicky pain. Actually, it is usually with a small bowel obstruction. What we want to remember from acute, severe, sudden colicky abdominal pain, and usually in the small bowel. Constipation in this case is usually late, while chronic constipation uh, 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 actually comes with mild abdominal pain, constipation, distension, and actually this is a picture of large bowel obstruction. So small bowel more likely to be acute, large bowel more likely to be chronic. Acute on a chronic, it's like short history of distension and vomiting with long history of pain and constipation. Sometimes they call it the the colonic obstruction or the large bowel obstruction that is developed to small bowel or as a lead to small bowel obstruction. So, and some literature says acute on a chronic, it's periodic actually, periodic non-severe pain for a long time. Subacute obstruction, it is when obstruction is on and off for a long period. And actually, if it's on and off, actually it's incomplete obstruction, incomplete or on and off obstruction. Closed loop obstruction, we will discuss it in the next few minutes. What does closed loop obstruction? So, depending on the type, we have acute, chronic, acute and chronic, subacute, and closed loop. Classification number 3 depends on the site of obstruction. Is it in the proximal bowel, small bowel, in the distal small bowel, or in the large bowel? Actually, this classifications lead us to the clinical, helps us in the clinical manifestations. Proximal to the small bowel, they mean actually the jejunum up to the ileum. Distal to the distal small bowel means the ileum, and large bowel it's from the cecum to the rectum actually. Here they review some causes of proximal small bowel, and they said that congenital, actually the congenital causes of of intestinal obstruction are more prevalent in the upper GI tract, in the proximal small bowel. So congenitals, lipomas, malignancies, leiomyomas, bands and adhesion. Examples for causes in the distal small bowel, tuberculosis, malignancies, Crohn disease. We know that Crohn disease is in the ileum most common. Gallstone, more likely to be impacted in the ileocecal valve and in the terminal ileum. Hernias, roundworms, congenital. Large bowel, it's anywhere in the large bowel, and here we have to think seriously about malignancy at the top of our differential. Tuberculosis structures, anorectal malformations, especially in the pediatric age group, volvulus, congenital megacolon. Actually, when they say congenital megacolon, they mean Hirschsprung disease and bands. So you can see that bands are bands more likely to be in the small bowel more than in the large bowel. Clinical features, what they want to say that in small bowel, actually in the small bowel the vomiting is more prominent than constipation, while in the large bowel the constipation and the distension is earlier than vomiting. So you can see here proximal and distal small bowel, vomiting, colicky pain, while in the large bowel it may be started with constipation and distension earlier, while vomiting can be present late. Okay, these special features, for example, on the X-rays in the proximal bowel, we will see what we call it the plica circularis or valvula conniventis. Actually, we will see a picture in the next few hours, in the next few minutes. I hope not hours. In the next few minutes, these are special structures in the jejunum become more prominent when proximal small bowel obstruction happens. The ileum, if there is obstruction in the ileum, actually, they always characterize it on the x-rays as featureless or characterless, with central fluid level, while large bowel we will see the haustration of the bowel more prominent. Another classifications, so this is the classification depending on site. Another classification is classification that depends on whether it's congenital or acquired. You can see here are different causes of congenital and acquired causes. Congenital causes, for example, anorectal malformations in pediatric age groups, congenital megacolon hair spring disease, adhesions, congenital bands, and duodenal atresia, intestinal atresia, bands and adhesion, malrotation, and valvulus neonatarum, while acquired hernia, postoperative hernia, postoperative adhesion, intussusception. Actually, intussusception can, okay, intussusception is acquired, yeah. Roundworms, gallstone, tuberculosis, malignancies, and internal hernias. We will discuss the term internal hernias in a detail. Okay. Another classifications is that which depends on the vascular compromise. There is the vascular integrity. So there is simple obstruction. When we say is this obstruction is simple, means that intact blood supply, no evidence of necrosis, no evidence of gangrene, no evidence. So while complicated means strangulated. Strangulated means there is diminished or compromised blood supply. Sometimes they include the closed loop obstruction as a complicated strangulated cause of obstruction. Some literatures include the closed loop in this classification. So simple means intact blood supply, while complicated means compromised blood supply. Other classifications, partial, is it partial obstruction or complete obstruction? Partial obstruction, there is some liquid or gases can get through the obstructive process, while complete obstruction, there are no passage of fluid or gases. Some notes we have to discuss together. Okay. Okay. And of the notes that we want to discuss here, for example, nowadays adhesion is the most are the most common cause of intestinal obstruction worldwide. Earlier in the past, it was hernia, while it's replaced by adhesion nowadays. Actually, some literature says classify it depending whether it's developed or developing countries. It doesn't a big deal, but we have to remember that adhesion is the most common cause. Hernia is the second most common cause of small bowel obstruction. Okay. Also here, adhesion commonly cause of small bowel obstruction than large bowel obstruction. 80% of intestinal obstruction is due to small bowel obstruction, while 20% is in the colon. 80% in the small bowel obstruction, and 80% of the small bowel obstruction actually is benign. You can see here 80% of intestinal obstruction is in the small bowel, 80% of small bowel obstruction usually a benign cause. If we are talking about the colonic obstruction, 70% of the colonic obstruction is due to malignancy. Actually, the most common cause of colonic obstruction is malignancy, cancer. The other 30% of colonic obstruction actually can be due to volvulus, to diverticulitis, to inflammatory bowel disease, Crohn's, or inflammatory causes, tuberculosis. Okay. The mortality of intestinal obstruction depends is there strangulation or not. It's three if it is not without strangulation, or it's simple obstruction. We said simple means no evidence of strangulation, and up to 30 if there is sign of strangulation. Recurrent obstruction usually is seen in adhesion, called adhesive intestinal obstruction. Okay. In pediatric age group, you can remember from the pediatric lecture that the most common cause of duodenal obstruction in a newborn, this means less than 1 week, it's actually duodenal atresia, while after 1 week it's malrotation. Some key points about large bowel obstruction. We said most likely to be malignant cause. If we are talking about colonic obstruction in children, the most common cause is Hirschsprung disease. Yes, and we will discuss this point later in details. But if perforation happens due to obstruction in the colon, so the most common site to be perforated is the cecum. Depends on Laplace law. Laplace law, we will see the more larger the diameter, the lesser pressure needed to cause perforation. So the cecum is the weakest point to for perforation. So we always pay attention to the diameter of the cecum. Sometime we can proceed, for example, perforated or tumor, obstructing tumor in the left side of the colon, and we proceed to subtotal or total colectomy because of the cecum is perforated or impeding of perforation. Okay, sigmoid volvulus also we are going to talk. These are just to refresh us. Sigmoid volvulus should be treated first with decompression, with endoscopic detortion. We will see in the next few minutes. We have to try, if no sign of strangulation present, to detour, to do endoscopic detortion, and then after placement of a rectal tube, then either electively, semi-electively, we can proceed for sigmoid resection. While cecal valvulus, these are two different entities. Actually, the sigmoid valvulus is the most common. Sigmoid volvulus more likely to be in elderly, cecal valvulus more likely to be in young age. Cecal valvulus usually is treated with right hemicolectomy, urgent right hemicolectomy. Many considerations or many explanations for why we proceed for right hemicolectomy. It's tolerated better. It's actually cecal valvulus more likely to be in young, so the recurrence rate on the lifelong is high, so it's best to treat it with right hemicolectomy. Okay, neostigmine is often successful in the management of acute colonic pseudo obstruction. Sometimes they call it Ogilvy syndrome, and neostigmine help us in understanding the pathophysiology of pseudo obstructions, as we will see in the next few minutes. You can see here the differential diagnosis of large bowel obstructions. I said do not pay extreme attention either this is intraluminal or intramural, because in different literature it can be different. So you can see here intraluminal means inside the bowel, intussusception, impacted material. If feces is impacted, so we are talking about stercoral foreign body, feces ulcer, foreign body, pissors and gallstone, and worms. These are inside the bowel, while in the bowel wall itself, in the bowel wall, malignancies, colon cancer arise from the bowel wall, inflammatory bowel disease, Crohn's, ulcerative colitis, okay, causing structuring, for examples. Iatrogenic trauma causes ischemia and eventually either perforation or structuring. Radiation, anastomotic structure, hematoma. Okay, extrinsic causes of large bowel obstruction: compression from outside, mass, neoplasia, abscesses, cyst, urinary retention when the bladder gets large. Pregnancy is one of the causes. Pseudo obstruction, volvulus, hernia, endometriosis. We will discuss briefly about endometriosis as a cause of either intramural or extrinsic. It can be intramural or extrinsic. The endometriosis can be extrinsic or intramural causes. Pancreatitis. We know that pancreatitis can cause paralytic ileus and can also one of the differential of large bowel obstruction, especially the transverse colon. Here one of the picture, I see it's basic, extremely basic, and I included in this lecture. You can see here obstruction without previous surgery. If there's no surgery, the small bowel, the most common cause, is hernia, while large bowel is cancer. With previous surgery, actually, what they want to say that adhesion is the most common cause in small bowel if there is surgery. If no surgery, we have the hernia. The large bowel, you can see it doesn't matter without surgery or with previous surgery, the most common cause is cancer. So we have to be alert for identification of the site of obstruction and be careful in colonic obstruction. Bullous obstruction, it's like foreign body inside the lumen of the bowel wall. Actually, these are bullous, intraluminal inside the bowel wall. Also, another picture: worms, gallstone, trichoepizores. These are the associated with psychotic disorder. You can see it over here. These are trichoepizores. I hope that the pronunciation is is correct, because to be honest, I didn't actually deal with one. I think pediatric surgeon deal with similar cases. Okay, phytoepizoars, it's any particles of food that can be locked in the bowel. Meconium, also foreign body. Food bullous, not digested well, especially in those who have problem in the oral digestion of food. Stercolith, these are the stercolith or stercoral ulcer, or you can see here the stool is impacted in I think diverticula, and here is stool impacted in the lumen of the bowel. So actually, definitely, this is not a cause of obstruction. This is extremely small to cause obstruction, but I bring it just to understand what does stercolith means. If we are talking about the pathophysiology, let's move a little bit to the pathophysiology. And about the pathophysiology, actually, at the beginning, the fluid that comes from the saliva, from the stomach, from the pancreas, from the duodenum, actually accumulate proximal to the site of the obstruction, whatever the obstruction is. And an edema in the bowel wall happens, which also aggravate the malabsorptive function. An edema in the wall, so absorption will be decreased. So the accumulation of fluids will be more. This lead to stasis of fluid, food materials, particles proximal to the site of the obstruction. This stasis will lead to bacterial overgrowth. This bacterial overgrowth can even spread to the lymph node, to locate in the lymph node, and causes ultimately sepsis. Fluid comes, as I said, from either the upper GI proximal to the site of obstruction, or it also comes from the circulation itself. fluid from circulation to the intraluminal space. This will lead to dehydration, and electrolyte imbalance. And actually, later on, air starts to accumulate. Air actually from where it's come. It's 70% from the, you can see here, 70% are from a swallowed air that we swallow. 20% is from the blood, from diffusion of oxygen from the blood, and 10% only from digested product and the bacteria as a result of degradation of the product. The gases that present, actually 90% of it is nitrogen. You can see here 90% is nitrogen and a little bit hydrogen sulfide, and we know that nitrogen is not capable for absorption very well. Okay, this will lead, this toxic material, this increased in the intraluminal pressure will lead to increased in the peristalsis called hyperperistaltic period. And so peristalsis or hyper peristaltic period, and due to this, some of air enter to the distal part, and this will lead us to the air fluid level that we see on the radiological imaging. We said that there is toxic material that are released, neutrophils, inflammatory cells such as white PCs, cytotoxins. These actually attack the secretory and motor end plate on the bowel wall, and they will cause aperistaltic period, or loss of the contractility of the bowel. And so this ultimately will lead to dilatation. This dilatation can be, as we said, due to the increased intraluminal pressure. Also, some theories about the role of nitric oxide in the dilatation and of the bowel wall and the permeability of the bowel wall. This dilatation will lead to, first, if it continues and not treated, will lead to venous stasis, actually, as the bowel wall pressure increases, so venous stasis happens, and ultimately arterial blood flow is compromised, which will lead to necrosis, perforations, and ischemia. Okay, actually, we discuss how the most important topics in the pathophysiology. Here are some pictures: intestinal obstructions, increase the peristalsis, and then if the obstruction is not relieved, peristalsis ceases, and paralysis happens. We discussed the most important. Here's the picture. Actually, it summarizes what's written above. They said this tension proximal to the obstruction, what happens? Actually, gas due to swallowed air, 70%, or from the blood, 20%, or from the bacteria, actually 10%. Mainly it is, as we said, nitrogen or hydrogen sulfide. Due to fluid, mainly of digestive, fluid, it comes from where? From the digestive juice, which normally get absorbed, but in obstructive absorptive ceases and accumulate fluid, causes bowel distension. And here, actually, in the lecture of IV fluid, we discussed that saliva is secreted in a rate about 1,500, gastric juice about 2 liter, bile about 500 to 1,000 milliliter, etc. All of these are accumulated proximal to the site of obstruction. And stasis lead to toxic built up. Peristalsis initially increased, as we said, called porporigmy, and to overcome the obstruction. At this point, some air can leak through the obstruction and cause the air fluid level that we see. Distal to the obstruction, actually what happens that what's remaining in the bowel distal to obstruction empties, and it remains contracted and silent. Okay, and they talk about what is the systemic feature of intestinal obstruction if left untreated: toxemia, septicemia, renal failure, acute respiratory distress syndrome, system of SIRS, and MODS, multi-organ failure. Actually, this is what happened. About the clinical features, you can remember we said the most upper, the GI obstruction, the more likely to be features of vomiting, and the more distal, more likely to be distension and constipation. So clinical features, these are abdominal pain. Initially it's colicky and intermittent, and later on the bowel get fatigues, and what happens, the pain becomes continuous and severe. Pain is the first symptom to develop, which is sudden and severe. Pain actually is the first symptoms. Initially it is colicky, and eventually it is persistent. Colicky means goes and comes, and then it becomes diffuse and persistent. Diffuse and persistent pain can suggest strangulation. Okay, pain begin around the umbilicus. This depends on the site. Some says colon obstructions give you a frame picture like pain on the periphery of the abdomen. Okay, in large bowel obstruction, okay, in small bowel obstruction, it's crampy, recurrent paroxysms, short crescendo descendo, decrescendo episode, 30 seconds, while in large bowel the episode of pain is longer, and so vomiting, we said in jejunal obstruction it's early and persistent. In ileal obstruction, a little bit, it's recurrent with interval, while in large obstruction vomiting is a late feature. Distension also, it is more prominent in large bowel obstruction while it's absent. Some says it's scaphoid in jejunal obstruction. Okay, constipation. Here is a nice, actually, what does constipation means? Here, lead us about the definition of constipation. I remember it when I was a medical student. What does diarrhea mean, and what does constipation mean? Painful defecation or rare defecation? What's the normal rate of defecation? Actually, this is not, but constipation is defined as infrequent or difficult evacuation of the feces. Typically, dry, hard fecal material is seen, while obstipation is one step further. It's a sequence of constipation. Obstipation is harder, or warm us, alarm us about more than constipation. Obstipation is one step further than constipation. It's characterized by inability to pass the accumulated of dry feces. There is a dry feces that not able to pass it. So this is the difference between obstipation and constipation. The conclusion: constipation is infrequent or difficult. Infrequent, how much? Actually, it's individualized. We have to talk with the patient to know his experience about or his bowel habit. Actually, dehydration can lead to renal failure if left untreated, and we will know the initial management. We will see that the initial management is fluid resuscitation. So you can see here that oliguria and ultimately can lead to failure. Feature of toxicemia, these are the clinical feature. Patient can present unstable with tachycardia, tachypnea, fever, sunken eyes, cold periphery, abdominal tenderness. Initially, it is localized but become more diffuse. Actually, rebound tenderness and guarding, these are present. If we have rebound tenderness and guarding, these suggest strangulation. These are not simple obstruction, so we have to be careful. Feature of strangulation, for example, strangulation again means we have a problem in the blood supply, we are losing the bowel. So feature of strangulation: continuous pain, shock, tenderness, rebound tenderness called Blomberg sign, guarding, rigidity, absence of bowel sound. These are signs of strangulation. Okay. Okay, temperature can be hyperthermic, hypothermic, doesn't. Bowel sound also an item to discuss separately actually. What's the normal bowel sound? Different literature, many literatures says it's from 5 to 30 in 1 minute. It's not our, but bowel sounds, you have to remember that bowel sounds is prominent in one phase of intestinal obstruction and absent in a later phase. We said hyperperistalsis. In the hyperperistalsis phase, where the bowel is contracting to override the obstruction, so we will hear a bowel sound, while later on we will not hear, it will be silent. Okay, the most common side to hear. So, okay, different literature. Some literature says you have to hear in the four quadrants, but actually we can take the classic teaching information in the right iliac fossa. What else I want to add about bowel sounds? Okay, they are increased high pitch metallic sound, followed by metallic tinkling sound of dilated bowel. Eventually, once fatigue occur or gangrene develop, bowel sound are not heard. Silent abdomen. Okay, I'm trying to remember what I want to say else about bowel sounds. The site, how many? Okay. Rectal exam, we always tell the medical student that rectal exam, PR, is part of the abdomen exam. If we can see, we can palpate the anal sphincter from the PR or per rectal exam or digital rectal exam. We can assess the anal sphincter. Is there any problem in the hyperspastic or extremely flaccid, any benign anal conditions, fissures, or on inspection. Also, we can feel masses. We can feel the prostate. Any rectal masses can be felt in the distal, of course, rectum. Also, if there is a stool, is it empty? If there is a stool, this will also help us. Okay, just here a study just on 150 patients about what is the clinical feature of intestinal obstruction. They found that cessation of flatus in 90%, cessation of feces in 80%, and abdominal distension in 65%. These are the most common signs. Okay. Other, we said that vomiting is later on large bowel obstruction. Okay, we discussed the other parts. Okay, let's move to the investigation. And of course, if you practice surgery, you know that with intestinal obstruction, we start with the plain X-ray abdomen, and here we can see the classic intestinal obstruction X-rays with air fluid level. many questions about how many air fluid level should I see. So it's difficult, but some literature says that up to 3 is normal actually, and the more air fluid level, the more severe the obstruction. Not only, but also the proximal obstruction, the less the air fluid level, the distal the obstruction, the more air fluid level. Okay, you can see here that normally 3 fluid level is seen. Actually, these are on the fundus of the stomach, the denum, and the cecum. Okay, what should I order? Supine X-ray or erect X-ray? Okay, actually, the most sensitive to or helps us it's to see dilated bowel loop. Actually, it's the supine X-ray. We prefer the supine X-ray. It shows us dilated loop and help us. While erect radiograph can shows us the air fluid level. If we have to start with the best technique, we start with supine and then we go for erect. And supine we see the dilated loops of small bowel. Okay, okay. Here is, I think there are better picture than this picture. Here is the air fluid level. You can see, we said that the more distal the obstruction, the more likely the air fluid level to be. Here is if there is a jejunal obstruction or jejunal dilatation, so we see what we already mentioned in the beginning of the lecture, the plica convenientis or the valvula convenientis or plica circularis. Here are they actually, these are structures that occupies the whole wall of the they become, actually they are normal, but they become more prominent when the jejunum is dilated, called the concertina effect. Concertina, actually, this music instrument. Okay. The ileum, we said it is characterless or featureless. In the large bowel, we see the haustration on the X-ray. Sometime we can see in the X-ray the pneumopelia, gas in the biliary tree. We know that gallstone ileus is one of the causes of intestinal obstruction. We can also, I don't think that it's wisdom to find this on the X-ray, it's more in the CT, but also distended cecum is shown as a round gas shadow in the right iliac fossa. Dilated cecum signifies large bowel obstruction. We have large bowel obstructions. Okay, small bowel diameter, to say that we have obstruction, the small bowel should be above than 3 centimeters. Some literature said 2.5. In this book, they said that small bowel on the X-ray should be above 3 centimeters in diameter, and on CT it should be above 2.5 centimeters. Okay. The proximal large bowel, that means the ascending should be above the 9, or the cecum should be above 9 centimeter. Transverse colon to say that we have obstruction or dilatation, it should be above 5.5. The sigmoid should be above the 5 centimeter. Should I have to remember this number? Actually, yes, as a preference, but this number is not a cutoff because it doesn't depend on a number per se. It depends also on the severity of the dilatation, on the gradual. Is it gradual or severe? Does it dilated to 5 or 6 centimeters within hours or within months or years? So the numbers is not a sole parameter. You can see here is suggestive for intestinal dilatation. These numbers are suggestive. Small bowel above 3 centimeter, large bowel above 9 centimeter. Here they mean the cecum and the ascending. Transverse 5.5, sigmoid above 5. These suggest intestinal dilatation, but This increase diameter need to suggest intestinal obstruction, but this doesn't. But sorry, let me check it. Mean that this number doesn't mean that intestinal obstruction is present. In some cases, we have congenital dilatation, so we have to remember that this number is not the sole preference for reference for us. CT scan, of course, it's our preferred modality. It's the highest sensitivity, the highest specificity. It it can picks up many things. For example, it shows us if there is dilated loop. It can see the transition zone, where is the dilated and the collapsed part. This is the transition zone. It can also figure out other nearby structures, so it's better than X-ray, of course. Here you can see in CT scan small bowel loop above 2.5 centimeters suggest dilatation, but not always suggest obstruction. It can show dilated loop, transition zone, and it can help us in the definitive feature of intestinal obstruction. Here you can see on the CT scan how the loops are dilated. Also, some features on the CT about the strangulation, if there is evidence of strangulation, if we are talking about the decrease of blood supply to the bowel wall, for example, if we have intramesenteric fluid, so be careful. If we have mesenteric edema, if the bowel wall thickness is more than 2 millimeters, so we are talking about strangulation, we have to be more careful. These are not picked on x-rays. Reduced mural enhancement. Okay, we can also pick the volvulus and its classic sign, the whirlpool sign. Actually, to see these, the picture should be dynamic. We should screw it up and down. Barium also is one of the modality to study in obstruction, but we have to remember if we have complete obstruction, we have to avoid barium as it may lead to barium peritonitis. We can use gastrographene instead. So barium either enema or barium enema or gastrographene contrast are useful for example in intussusception. It can be therapeutic and diagnostic. Here barium meal, it's when we take barium orally, is contraindicated in acute intestinal obstruction. However, diluted barium actually, or gastrographene meal full throw, can be taken with caution. It should be the suspicious should be either subacute or partial. If we have complete obstruction, it's not preferred as this may lead to barium peritonitis. Okay, and of course the laboratory investigations, the hematocrit, blood urea, nitrogen acidosis is common actually, arterial blood gases, creatinine, we have to check the kidney function, the liver function, the platelet count. If we have sepsis, there will be altered liver function test with thrombocytopenia, serum electrolytes, especially the hypokalemia. Ultrasound abdomen, this depends actually. It's better than X-ray and between the X-ray and the CT scan, but actually this is operator depends on the radiologist. He's expertised enough to pick up the dilated bowel loop and air fluid level. As we said, it's better than X-ray, but not as good as CT. Actually, we can use Doppler ultrasound to check for sign of strangulation. Another modality to check the rhythm, the electrical activity of the bowel wall or the small bowel wall is the what we call squad device. This is a superconducting quantum interference device. This device actually is have many medical appliance. One of them is to check the basic electrical rhythm of the small bowel, which will be decreased in ischemia. So it can help us is there is evidence of strangulation or not. I didn't see it in my practice. So let's move a little bit to talk in details about imaging a small bowel. About the investigation or the imaging of the large bowel, just we have to remember that in some cases, while taking physical exam and history, we suspect large bowel obstruction, but in about third of the patient, one third of the cases on imaging, we didn't find any causes, and also in 20% of patient that thought to have colonic pseudo obstruction means no mechanical cause, we pick a mechanical cause on radiological imaging. So the radiological imaging can help us. Okay, here they just explain that all actually we start with abdominal plain film. We start with this. Actually, they said the supine. If we need additional, we can go for upright, standing. X-rays, the sensitivity actually it's less than the CT scan. Here they talk about the column diameter. It varies from 3 to 8. If you want to remember a one number, it's the cecum dilated in acute situation above 9 centimeter, and the other colon, other parts of the colon, excluding the cecum, is above greater than 6 centimeter. The CT, we said that it is the modality of choice in intestinal obstruction, carries as high sensitivity approaching the 90s and specificity. Also, CT scan can help us in picking pneumoperitoneum, nematosis intestinalis, and portal vein gases. Pneumoperitoneum and portal vein gases are more specific for perforation or strangulation, while nematosis intestinalis is not specific. It's not pathognomonic actually. Nematosis intestinalis means mucosal integrity is disrupted. It's not pathognomonic for intestinal obstruction, not pathognomonic for anything actually. We can see it in patients who are taking corticosteroids, for example, so they are not indication for surgery. For example, also in contrast, we can see that portal venous gas and pneumoperitoneum, intraperitoneal air, are more likely to be associated with transmural ischemia and necrosis. We said that the sensitivity of the CT scan is higher when we compare it to X-rays. What also we can add here? We said that the common site for perforation is the cecum, so it's wisdom to measure the cecum if we suspect. Perforation rate in colon in colonic obstruction is about 3 to 8 percentage. Okay, it's actually the CT help us in picking up the malignant causes. Actually, when we see especially the transition point. Transition point means that the proximal is dilated, distally is collapsed, and we can see the shouldering. You can see here the CT scan. Here is, I think, a lesion in the transverse colon, while the ascending is dilated. We can see here that the valve here is working, it's competent for, so it's like a closed loop. Here it's competent, no reflux of material, and here it's also there is obstructing lesion, so this is like a closed loop obstruction. Okay, they also continue to talk about the CT scan and how it's important. It can be used to assess any lesion in the bowel, synchronous lesion in the bowel, although it's not ideal for detecting synchronous lesion, but it can help us. Okay, it can also help us in seeing if there is local invasion to the bladder or the small bowel. These are picked with a CT scan. Okay, they talk about the ultrasound, nothing. MRI is like CT scan, but it's not always available. It needs an expertise radiologist to study. But one of the advantages that it is an radiation free, uh, especially for example in pregnant women we can use it. And they also talk about the water soluble contrast, which carries a high specificity and sensitivity, but of course it cannot give us indicator about the etiology like the CT scan. Okay, the initial management for a patient with intestinal obstruction. The common procedure that we have to do for intestinal obstruction, whatever the site or the classification or the type, we have to put the patient nil by mouth. We have to proceed for nasogastric aspiration and G tube. And G tube actually it decompress the small bowel, so it releases the dilatation a little bit, and also it prevents aspiration, and so prevent any respiratory compromise. It reduces the toxic effect, reduces the bowel distension, and also it improves the pulmonary function. IV fluid replacement, extremely important to replace fluid. We said that third spacing and fluid loss is significant. We have to measure the urine output. Also, in some cases, if strangulation is present, we can add antibiotics. And some patient may need blood transfusion and critical care even in the ICU, to be admitted in the ICU if there is a complication like acute respiratory distress syndrome or SARS or DIC. Some patients may need vasopressors such as dopamine and butamine, or even CVP monitoring and PCWP, pulmonary capillary wedge pressure. These are also modalities to deal with patients with intestinal obstructions who are critically ill. When to proceed for surgery, we said at the beginning of our lecture that this will lead us to the diagnosis, and every diagnosis have different approach. But what is in common? Immediate laparotomy is done at the site if we have complete obstruction or strangulated complicated type of obstruction. We see that we have to find the junction between the proximal dilated and the distal collapsed, and to relieve this obstruction. How we will relieve it, we will see. The obstruction should be relieved. How depends on what is the cause. Is it adhesion? Is it a tumor? Is it band? Is it gallstone ileus? Depends. We relieve the obstruction. Laparotomy, relieve the obstruction, and then we have to assess the viability of the bowel. And I advise you to see, it's discussed well, the viability of the bowel in the lectures, in the stoma lecture. We have 4 or 5 techniques to check the viability of the bowel. Should we proceed for anastomosis, or should we resect, or should we bring a stoma? This is one of the modalities to check the viability of the bowel is the fluorescence study. Indocyanide green test, extremely important and new technique to study the viability of the bowel. I think it's abbreviated ICD, indocyanide green test, ICG, something like that. Actually, it's a fluorescence study. Other modality to check the viability is to see the peristalsis, to see the bleeding from the edges. What's else? To feel the pulse in the mesentery. These also, all are modalities to check the viability of the bowel. Here they summarize some peristalsis, pulsations, pulse on the mesentery, bleeding. If there is pulsatile bleeding, this means good blood supply. The color also. They said that we can put a warm mop or warm swag goes on the bowel so it will regain its if of course it's questionable, if the viability is questionable. Here warm saline swag mop is placed over the ductful area with 100 oxygen for 20 minutes and reassess. Of course, we have to think of drains. We have to do wash out good with large amount of saline. Abdomen is closed with non-absorbable and the small bowel can be decompressed. Actually, this is one of the technique of how we can resect and do anastomosis of the small bowel and preventing future structuring called the Cheatley slit. Cheatley slit, you can see this is the Cheatley slit. Here it is. Actually, it widened the site of the anastomosis. Here is the steps. Here is the gangrenous part which causes intestinal obstruction. We resect and they close the mesentery. You cannot hear. They do anastomosis. Here is the Cheatley's cut. They do anastomosis and here they close the mesentery. It can prevent future internal hernia. Some basic principles: if we have, for example, right side colon obstruction, more likely to be malignant, we have to proceed for right hemicolectomy with iliocolic, or sometimes we call it iliotransverse. You can see here right side resection with iliotransverse anastomosis. Depends on the viability of the bowel and intraoperative assessment. So this is if we have right side colonic obstruction. If we have left side colonic obstruction, where is it? They mean the cecum, for example, the sigmoid, for example. If we have left side, left hemicolectomy, we can do left hemicolectomy with colocolic anastomosis is done with a defunctioning colostomy. The colostomy is done in the transverse, on the right side or the transverse. Actually, leak in the distal part of the abdomen is devastating. And leak is less common in right-sided anastomosis. So when we do an emergent operation on the right side of the colon, we proceed for right hemicolectomy with the primary anastomosis and everything is fine. If we proceed for surgery in the left side, so we have to think about a type of defunctioning colostomy or defunctioning ileostomy. We may proceed for ileocolic anastomosis with loop ileostomy. So we have to think the more distal the obstructing lesion, we have to think if we are going to do primary anastomosis, we have to do defunctioning colostomy. Here the advice on the right side, defunctioning colostomy or in the transverse, and to be closed later after 9 weeks. In cases of rectosigmoid obstruction and the patient is severely ill, yes, Hartmann. Hartmann, I think there is a picture here about Hartmann. Here is it. Let me do. If I have a sigmoid problem or yes, sigmoid or distal rectum, we can just bring a colostomy. We bring this, we take the part and we suture this part. This part it is sutured and we will discuss this in a detail later. Should we take the tumor or just leave it in the abdomen? If we have a tumor, should we take it with a specimen or just bring a stoma, close the stump and leave it in the pelvis? We will discuss it later, but Hartmann solution is one of the solution. Hartmann operation is one of the solution of obstructing lesion in the sigmoid or rectosigmoid junction. If we are talking about distal or mid-rectum, don't think. The answer is loop colostomy. Do loop colostomy. Okay. In some cases, you may need second look operation to look for the viability of the bowel. So we said cancer in the sigmoid, they proceed for Hartmann operation if the patient is severely ill, unstable. We can proceed for primary colorectal anastomosis, but this depends on the surgeon experience and the status of the patient. Okay. And we said abdominal colectomy and ileorectal anastomosis. One of the surgeries that I proceed for about 2 months ago, it was a tumor, I think, in the descending colon, but the whole colon were massively dilated with necrosis of endocecum. So we proceed for subtotal colectomy, ileocolic anastomosis, and defunctioning loop ileostomy. So this is one of the solution in emergency surgery. Cancer in the distal, we said anything, any problem, any emergency obstructing lesion in the rectum, loop colostomy. The laparoscopic approach nowadays for obstructing lesion, okay, is useful, but in partial obstruction. If there is, we will see that laparoscopic approach, emergency surgery, obstruction. If it is a single band, if it is adhesion, so we proceed for limited adhesolysis, it can help us. You can see here it's useful in partial obstruction, useful in proximal obstruction, useful when there is a band, but conversion when needed may be done without hesitation. Okay, we just reviewed what does intestinal obstruction means, some investigations. We are now going to talk in details about some special consideration. For example, you see in this slide the adhesion and band. I know that most of you knows that this is a very basic, very simple subject to talk about. We want to learn some skills about and informations about adhesion, new informations about adhesion and bands. Closed loop obstruction, what does it mean? Pseudo obstruction, what does it mean? How can we treat it? It's step by step ladder. Volvulus, we will highlight. What does ileosigmoid knotting mean? Hernia, of course, we are going to talk about hernia in a limited fashion. The other category I put it together: duodenal atresia, intussusception, intestinal atresia. You can see it here actually. These malrotation mechanisms, these are causes of intestinal obstruction. I know, I can hear you that these are in the pediatric age group most likely, so you can see it. They are explained in details and will in the pediatric surgery lecture. We will take a look about how can endometriosis and infection can causes obstruction, and at the end of this lecture we will see some principles of how to deal with malignant large bowel obstruction. It's extremely interesting for those who are interested. Okay, now we move to adhesions and bands. Okay, dear colleagues, and now we start our second part of this lecture, and we are going to discuss in details about some special consideration in intestine, some special diagnosis or some special subjects in intestinal obstruction. And first we are going to talk about adhesions and bands. And as we already mentioned, nowadays adhesions is becoming the most common cause of intestinal obstruction, particularly small bowel obstructions. And in some literature they differentiate developing and developed country. It's not our interest right now. And you can see that the causes of adhesions and bands can be infective due to peritonitis, appendicitis, even if not operated. We are talking about appendicitis that may resolve on medical treatment, for example, post laparotomy. Okay, and other causes. Any infection can cause adhesion. Other causes of adhesions is the material that we can use that we may use during surgery. You can see they can cause dense inflammatory reactions such as suture materials, silk thread, foreign bodies, mops and gauze, talc powder that is used in some gloves, and certain drugs such as sulfonamide and penicillins. Ischemia to the bowel with the variety of the causes that may cause ischemia. For example, we are talking about sepsis, we are talking about venous ischemia, arterial ischemia. Any cause of bowel ischemia can lead to adhesion. Gynecological conditioning, as you see here, bowel injury, radiation, Crohn's disease, and other inflammatory bowel disease, and some specific conditions such as tuberculosis and malignancies, of course, they can cause lead to adhesion. The item of adhesion in the small bowel is called adhesive small bowel obstruction. You see it's abbreviated ASPO. Okay, the causes, other classifications or how to review the causes of adhesion, or they are classified to congenital adhesions. Some of the adhesions can be congenital, as we will see in, for example, macal or vitalointestinal duct bands or lad bands. I think they are mentioned here. Okay, and ischemic induced, we said congenital adhesions, ischemic induced blood supply, reduced blood supply to the bowel. Actually, we will see in the next few seconds that some adhesions are formed to maintain the vascular supply to an ischemic part of the bowel. They are vascular, actually. Not all adhesions are avascular. Some of them are vascular, and they participate on maintaining the blood supply to an part of the bowel that is ischemic. Okay, I hope that I delivered the information in a simple word. Okay, we said ischemic, congenital, traumatic. For example, post-laparotomies, irritant, they classify it, for example, talc powder that's used in the gloves, stretches, antibiotics, and gauzes, etc. Inflammatory such as cholecystitis, appendicitis, Crohn's, tuberculosis. Actually, many medical literatures are from India, and they highlight on the tuberculosis as a cause of adhesive intestinal obstruction. Other causes here also as serosal denudation. They mean serosal injury can cause or participate or precipitate adhesion. Okay, the sequences actually start as ischemia, then inflammatory exudate. I want you to differentiate here between fibrinous adhesion and fibrous adhesion. We will see in the next few minutes that these are two different types of adhesion. Fibrinous adhesion, which is avascular, and fibrous adhesion, which are vascular adhesion. Okay, here you can see that fibrinous adhesion is avascular. Okay, the adhesion can be localized and even extensive. I know many of you practice surgery and know what does extensive adhesion means. Okay, the types, as I said, there are mainly two types. The first type is fibrinous adhesion. These are early adhesion. They are what you have to remember. Fibrinous, early, within 5 to 10 days post laparotomies, post surgical period, and they are avascular. Type 2, they are fibrous adhesion. They are vascular adhesion, and the aim of this, or the rule of this adhesion, actually you can see here, they are due to poor blood supply. So bowel get attached to part of the omentum, to part of the peritoneum, so that part can supply the ischemic part. We have to remember that they are vascular. So this adhesion can maintain blood supply. Okay, okay, you can see here adhesion due to tuberculosis is severe and difficult to separate. The investigations, our usual investigations, we start with plain X-ray and we can proceed to abdomen CT. The treatment is also our initial management start with IV fluid resuscitation and alt. Excuse me. Okay, let me see. It's recording. Yes. Okay, we start with fluid resuscitation with nasogastric aspiration, antibiotics. Okay, it depends on whether there is sign of strangulation or not, and also rectal tube or per-anal flatus tube. Also, this depend on the severity of the picture of where is the obstruction is. So it's not routine to put a per-rectal or per-anal tube. Also, here it's written that commonly will resolve within 4 to 5 days. Some literature says that do not wait more than 72 hours. Also, this depends on whether the obstruction is partial or complete, sign of strangulation or not. Okay, later treatment, or we can call it definitive treatment for adhesion. Actually, the best treatment is to prevent the adhesion, but we have a rule of either open adhesolysis or laparoscopic adhesolysis. Yes, laparoscopic adhesolysis is becoming more popular, safer, faster, but the band should be single, limited, not that extensive. Many laparoscopic adhesolysis can be converted to open. Some operation, I'm not sure of its benefit. I didn't review the literatures or studies about them, but they are written in many literatures about how these are surgeries to prevent recurrent severe adhesion in the small bowel. Of these, they are classified as external plication. Plication is like fixation, the small bowel, or internal plication. Of the external plication, we have Knopfler's plication of the intestine. You can see these are for recurrent adhesion. I didn't see similar surgeries in my practice. You can see here they actually sutures the small bowel to each other so that adhesion could be prevented, called Knopfler's plication. Other modification of Knopfler's plication is called Child's Phillip mesenteric plication. Actually, these are sutures. It's application or fixation the small bowel together. I'm not sure of its benefit. I have no idea, but we have to mention them. Child's Phillip mesenteric plication. Actually, this is Child Phillips, and this is also Child's Phillips plication. These are sutures, the three sutures, and this is the mesentery. They fix it. Okay, this called external plication. And internal plication, you can see here internal intestinal plication, or another name internal tube splinting or sutureless plication. These are just a tube that pass through the small bowel so the small bowel can be maintained open. Also, you can review the literature and tell me, is it advisable or not advisable these days? I think okay. Okay, this is the internal intestinal plication. You can see here a tube is inserted through an external, I think, external opening. It could be through an external opening, for example, in the jejunum, so it's called Baker tube, or it can be from the stomach down past, and then it will called Stewardson insertion. You can see this is the internal type of application for adhesive, for severe recurrent adhesion. Okay, some uses expandable Tiffy membrane barrier. Some uses hyaluronic acid. Okay, here are modalities to prevent the adhesion installation of drugs such as hyaluronidase, steroid, dextran, polyvinyl, silicone, fibrinolysis, streptomycins. It's not a matter to remember these agents, but a matter of does they benefit. I'm sure that the literature, or if you want to review the literature, there will be doubts and non conclusive result about its benefit. Does hyaluronidase proven that it prevents adhesion or not? I'm sure that studies will be conflicting. Okay. Other modalities to prevent adhesion is the gentle handling of the bowel. That's correct. Prevention of spillage if we can, intra-op, spillage of what? Spillage of like of feces. Also peritoneal wash with warm saline, 8 to 10 liter, also can play a role. Also careful placing of a drain, and laparoscopic procedure as we can. Laparoscopic is associated with lesser chance of developing adhesion. Okay, and adhesion due to pans, you can see we said adhesion due obstruction due to adhesions and due to pants, mostly single pants such as in vitellointestinal and bands. We said that of this band is the vitellointestinal duct lad bands, omental band, post-surgical fibrous band, tuberculosis band. These can be managed either laparoscopically if we can, or laparotomy. Okay, let's move to an important topic in intestinal obstruction, usually discussed in the lecture of intestinal obstruction, and these are the closed loop obstruction. What does closed loop obstruction mean? Okay, and to imagine what this closed loop obstruction means, let's skip a little bit to this picture. You can see that we have an obstructed part of the bowel here. There should be the obstruction should be in a 2 point, proximal and distal, and so this part will be closed, and the increased pressure will not relieve through the distal or proximal segment, so it's capable for strangulation more than non-closed loop obstruction. It can come in two scenarios. Either this picture you can see whatever the condition here, is it band, is it hernia, is it volvulus, or another scenario, important scenario, when obstruction in the colon happens, either in the ascending, descending. Here the give an example of the transverse. There is a tumor here or obstruction, whatever, and this valve, the ileocecal valve, is competent. It's working well, so it prevents reflux of the fluid and fecal material backward to the retrograde to the small intestine, so it doesn't empty. So what happens is closed loop obstruction. We have distal obstruction and proximal patent competent ileocecal valve, so we have closed loop obstruction. What happens when the obstruction in the large bowel, as we see, when the obstruction in the large bowel, there should be an ileocecal valve competence, so the pressure increases, and we will see that according to Laplace law, the Laplace law, you can see here, state that intraluminal pressure requires the intraluminal pressure that is needed to stretch the bowel wall is inversely proportional to the radius of the tube. We have the cecum with the largest diameter, so it needs minimal pressure to increase the tension on the wall. So perforation, mainly in closed loop, happens in two main parts. Either the site of obstruction, for example, if we are talking here, either in this site where the obstruction happens, where the tumor present or whatever the lesion, or in the cecum. So This is clinically important. We have to check the cecum. It could be perforated or pending perforation, and this can lead us to a patient with, for example, localized obstruction, but we proceed to subtotal or total colectomy because the cecum is pending perforation or it's not healthy. So we have to check the viability. For example, if we are talking here, the obstruction or the perforation or the gangrene can either present here or at the top of the at the apex of the obstruction. Okay, let's return back. We said competent ileocecal valve, so gangrene will happen. It's lead to perforation, to peritonitis. Okay, we said that can occur. Also, other scenario that closed loop can occur either when there is both proximal and distal part of the loop. They are talking about this one. Okay, necrosis and perforation is common. Some says that closed loop obstruction is part of strangulated obstruction or complicated obstruction. Okay, the ileocecal valve is patent in most of the patient, in about 75 of the patient. Laplace law, we discuss it. The more the radius, the more the diameter, the less the pressure needed to inflate and increase the tension on its wall. Okay, okay, okay. Okay, it's important also here to notice that it's not just measuring the diameter or the size of the cecum per se. No, it's also the acuity, because the cecum can get significantly large on a long period, so it accommodates. So we have to take to know the trend, they call it. Is this dilatation happens on a short period, so the risk is high, or in some patients it could be high on a long period and doesn't cause any perforation. So the acuity of the presentation and the rapidity of the cecal distension may be more important in determining the risk of perforation than the cecal size alone. Okay. Another entity discussed in intestinal obstruction is the paralytic ileus, and you can remember we classify intestinal obstruction to dynamic and adynamic. This is an important example of adynamic intestinal obstruction, is the paralytic ileus. Okay, actually multiple theories about how does paralytic ileus happens. We will discuss it. It's similar to called acute colonic acute colonic pseudo obstruction, but it's for the colon. Ogilvy syndrome. We will discuss the pathophysiology. It's the similar, but as a hit or as just a simple information, it could be that the causes or the pathophysiology, it's due to failure of transmission of peristalsis due to failure of neuromuscular mechanism. We know that the neuromuscular mechanism is due to Auerbach or mesenteric plexus, which is present in the wall of the intestine. Okay, the paralytic ileus can be localized or generalized. In this literature is not mentioned, but there is an item called prolonged ileus, even that may permit more than 2 weeks, and it's very challenging to deal with. Okay, the causes, different causes. Post-operative ileus, as you know, and again many of you practice surgery and knows how it's difficult to deal with post-operative paralytic ileus, especially if it's prolonged ileus. Infection can cause paralytic ileus, such as pus, bile, toxins, uremia. And I always want you to remember that it may cause what we call spastic ileus. Spastic ileus, it's hyperperistalsis of the bowel wall. Hypokalemia, we know that the most common electrolyte that may cause or have surgical significance, spinal injury actually, and actually any surgeries in the spine. Okay. Spinal surgeries, they mention it here. Retroperitoneal hemorrhage, retroperitoneal surgeries, renal surgeries, and plaster jacket. Okay, here is another picture also reviewing the causes of paralytic ileus. And of these are surgeries, uremias, infection, peritonitis, pneumonia, electrolyte imbalance, not only hypokalemia but also hypomagnesemia. Hyponatremia can also lead to paralytic ileus. Anticholinergic drugs, opiates, morphine can cause paralytic ileus. Phenothiazide, calcium channel blocker, antidepressant, hypothyroidism. It's like a medical cause of intestinal obstruction. Okay, retroperitoneal hemorrhage, colic, spinal cord injury, infarction, mesenteric ischemia, also a common cause of adynamic intestinal or paralytic ileus. The clinical picture, it differs a little bit of mechanical obstruction in that the pain is less severe, distension is prominent, and actually gas is present. If we are comparing mechanical obstruction and non-mechanical or paralytic ileus, we will find gas in the distal. In paralytic ileus, we will find gas in the distal bowel and in the rectum, while mechanical obstruction, it will be gasless. So you can see here the clinical picture of paralytic ileus. No passage of flatus, no bowel sound. Actually, the bowel sound is hypoactive, while in mechanical, it's hyperactive at the initial phase. Marked abdominal distension, tachycardia, vomiting. Tachycardia, we said, respiratory distress, as usually there is a compression or pressure on the diaphragm. High pitched tingling note. It's like a pulse. Okay, it's initially high pitched tinkling note. It's the bowel sound. Dull abdominal pain, not colicky. Actually, it's less severe. Dull, less severe or absent pain. Okay, and feature of fluid, protein, and oxidative balance. Here they compare the mechanic paralytic ileus or adynamic and the mechanical cause, the dynamic. We said that the pain is not a feature, or if it's present, it will be dull, it will be diffuse, steady. Bowel sound is hypoactive or absent, and the presence of gas in the colon and rectum. While in mechanical obstruction, absence of gas in colon and rectum, the bowel sound initially are hyperactive. Investigations, actually we have to look for the causes. Of course, we have to check for serum electrolytes, especially the potassium, ECG, if that can give us a hit, abdominal x-ray and CT and ultrasound. Of course, we should treat the underlying pathology. Initial management, common initial management for intestinal obstructions and G-tube, treating the primary causes. If we have problem in hypokalemia, we should treat hypokalemia. If we have peritonitis, we should treat the cause of peritonitis, and etc. Okay, catheterization and to measure the urine output. And here they do not stimulate peristalsis. Do not give, for example, metoclopramide or streptomycin to stimulate the peristalsis. Here a nice proverb: do not flog a tired horse. Okay, so it's mainly how to treat the underlying pathology. We can use of course rectal tube in some cases to decompression for not permanent, transitional. The ileus mostly resolve within 3 to 4 days. I have also again to mention here that we have an entity called the prolonged ileus. And a prolonged life-threatening paralytic ileus, even laparotomy is the treatment. A regimen which we rarely use for paralytic ileus is the catch-pole regimen. It's using neostigmine, which we know it's a cholinergic stimulation, plus adrenergic blocking agent together to release the paralytic ileus. It's rarely used nowadays. Also, if you are interested, you can view the literatures and the studies about this. About this picture, I see it. It's a little bit interesting. It's about the return of normal motility. The post-ileus, post-surgical, for example, if we are talking about surgery, we have ileus, and so the return of the motility of the small bowel, we start with the small bowel. It first will return to its activity within 24 hours, then the gastric up a little bit, the gastric within 2 days, and the colon, it takes 3 to 5 days to resolve. The most common site for post-operative ileus is the colon, actually. And different similar entity is what we called acute colonic pseudo obstruction, and abbreviated ACPO. Okay, and let us see what's new, what we can add in acute colonic pseudo obstruction. It's similar to paralytic ileus. Sometimes acute colonic pseudo obstructions called the Ogilvy syndrome, or colonic ileus, acute colon. Okay, and about the pathophysiology of the acute colonic pseudo obstruction, it's usually imbalance between the parasympathetic and the sympathetic. We know that the parasympathetic is responsible for the motility of the bowel, and sympathetic for in decreasing the motility of the bowel, or cessation of the motility of the bowel. So we have parasympathetic inhibition and sympathetic stimulation. This will lead to impaired the colonic motility in the absence of mechanical source. Okay, what else we can add? Okay, here they said that the exact pathophysiology is not clear, but actually autonomic dysregulation is likely, and multifactorial can predispose, multi causes or multi-factor can predispose to this entity. Okay, it's rarely a primary diagnosis, and usually it is a consequence of other active illness. Okay. Okay, as we said, we should review the other underlying pathology. It's similar to paralytic ileus, the causes can be different. Okay, what else we can add here? Usually these patients are elderly, they have multiple comorbidities, they are usually hospitalized for other acute illness, non-operative trauma, metabolic abnormalities, surgeries, including the CS surgeries. Okay, also medication play roles, such as those who affect these medication that affect the colonic motility: opioids, calcium channel blocker, psychotic medications also play a role. Okay. The signs and symptoms: this abdominal distension, nausea, abdominal pain, diarrhea, absent bowel activity. Respiratory symptoms can be present if we have severe distension that may compress or displace the diaphragm. Okay, perforation can happen and lead to tenderness, sign of sepsis. This may signify ischemia with impeding perforation. We have no accepted definition or criteria for to diagnose acute colonic pseudoobstruction or Ogilvy syndrome, but on imaging, measuring the cecum can help us if it is the cecum diameter is above 9 centimeter, or other segments of the colon above 6 centimeter. This may help us in saying that it is mostly acute colonic pseudo obstruction. You can see this picture. The Actually, we know, we will see in the next few seconds, that the autonomic innervation of the bowel have a transition point in the splenic flexure, and this actually support the explanation, the theory about colonic obstruction. Most likely, we found that acute colonic pseudo obstruction have a transition zone between dilated, uh, uh, immobile bowel proximal to the splenic flexure with normal distal to the splenic flexure. And so you can see in this picture how is the ascending and the transverse is dilated. This is the splenic flexure, and distal it's collapsed. So this this may help us. You can see here a transition to more normal colon in the splenic flexure. This is related to the autonomic blood supply of the bowel. Here is a picture of course, we have to rule out mechanical cause. If you remember, we said about 20% of patients diagnosed with pseudo obstruction on imaging we found a mechanical causes. Okay, we said that a transition point. Actually, the splenic flexure is a transition between the midgut and the hindgut. In this place, actually, we have a problem in the parasympathetic and sympathetic innervation, and this leads us to a kind of mechanical obstruction or aganglionic segment in the splenic flexure. So that the cecum is dilated, transverse is dilated, while the descending will be usually normal. Okay, what's else? Here they say it's important to confirm that there is no mechanical obstruction. Okay, what's else also in the sometime CT is not enough to rule out mechanical obstruction. We may proceed to water soluble contrast enemas. Okay, the causes or the predisposing factor of acute colonic pseudo obstruction can be similar to Elias. It doesn't explain why obstructions happen, but these are risk factor, predisposing factor, uremia, electrolyte abnormalities, which we already discussed. Okay, an entity such as toxic megacolon can cause, for example, can be due to infectious causes or inflammatory bowel disease. Okay, they mimic acute colonic pseudo obstruction. Okay, nothing else. So here we are talking about the treatment. The treatment can be divided to medical therapy, to pharmacological therapy, as we will see, pharmacological therapy, and colonic decompression, and even surgical therapy. This is how we treat acute colonic pseudo obstruction. Let's discuss the medical therapy. Medical therapy of acute colonic pseudo obstruction. First of all, we have to ask ourselves, is there a sign of strangulation? Is there signs of perforation, signs of ischemia? And we have to look where? To the cecum, as it's the most part to be affected, according, as we said, to Laplace law. Okay, you can see in this picture how the cecum is dilated about 14 centimeter. Okay, again, to say that we have to know that it's not taking just a number as a cutoff for our intervention. It's also the acuity, the duration that is needed to make this cecum dilated. It can be gradual, chronic, and the number may be huge with no with accommodation and no risk for perforation. So the acuity is extremely important. Okay, we said the cecum is the highest risk for perforation. The mortality rate in acute colonic soda obstruction in cases of perforation is high, up to 30%. Okay, what else we have to notice? The medical treatment include that power rest, also treating the causative, the underlying condition. For example, if the patient taking narcotics, we have to stop it. If the patient have thyroid disease or hypothyroidism, we have to treat it. We have to encourage the ampulation. Okay, correcting the metabolic derangements if they are present, and if we have to remember that these patients are elderly, these patients are immobile, so in general, laxative uses, diarrheal agent, for example, we have to avoid because these can increase the intraluminal pressure. These measurements actually are encouraging the ampulation, treating the underlying cause if we know it, for example, electrolyte abnormalities, etc. And also, we may proceed for NG tube and etc. These medical modalities can help us in resolving about 75 of the patient. Okay, what else? When we can proceed to what we call it the pharmacological treatment, it's actually the neostigmine we will see. But when we can say that we failed medical treatment or conservative treatment, when we fail, when there is fail to improve within 2 to 3 days, plus we have a cecal diameter about 12 centimeter and above, so we have to proceed to what we call the pharmacological treatment. I like this information. It's about, I know that I repeat it more than 3 to 4 times, but it's interesting. I read it here. I found it here. It's about the acuity of the distension. Okay, I don't know where I found it actually. Here is it. The duration of the distension and the acuity of how quickly the colon distended is are more important factors and contribute to perforation even in cases of less extreme cases. These are talking about the risk of perforation if the cecal diameter is dilated. It's regarding the acuity and how quick the colon is distended. It's not taking just a number and be happy of it. Pharmacological treatment. And here we are talking about neostigmine. We should think like that. We need an agent to increase the parasympathetic activity or parasympathomimic activity, which will lead to increase the concentration of acetylcholine. So neostigmine works like this. It's a competitive acetylcholinesterase inhibitor. So it inhibits the product that degrade the acetylcholine. So it's an acetylcholinesterase inhibitor. So reduces the breakdown of acetylcholine and so increases the acetylcholine concentration and so it increases the parasympathomimetic action. Okay. It's effective when medical therapy fails in about 90% of patients with acute colonic soda obstruction. Actually, the dosing, we have a result within 10 to 30 minutes. Redosing can be done. Redosing can be done even on those who did not respond with a successful rate about 50%, 40 to 100%. So redosing is considerable in failed situation. Just I want you here to see that we give it intravenous. Some some can be given sub-Q, we will see, and typically it's 2 milligram over 3 to 5 minutes. The clinical response will be after 10 minutes, and the half-life is about 60 minutes. Okay, we have successful decompression. Proceed please to daily polyethylene glycol. Here is the neostigmine, here is the polyethylene glycol. It prevents, studies shows that it can decrease the risk of recurrent acute colonic soda obstruction. Okay, many side effects for neostigmine. We know it is sympathomimetic, so it can lead to bradycardia, to respiratory distress. So in some centers, and even in the centers where I work, when they give neostigmine, they used to give it in the ICU conditions. So we have to do continuous monitoring, and some medication should be available, such as atropine. We said bradycardia is one of the side effects. Atropine should be ready. Cardiac and respiratory support or resuscitation should be ready. Some of the side effects we can overrid of these side effects. For example, we have of the side effects bronchospasm and hypersalivation. We can give concomitantly with neostigmine. We can give glycopyrrolates to prevent bronchospasm and hypersalivation. Of course, it's contraindicated when there is mechanical obstruction. It's contraindicated when there is urinary tract obstruction. It's contraindicated when there is bradycardia. I'm not talking here about is it absolute contraindication or relative contraindication, but asthma, renal insufficiency, peptic ulcer disease, and recent myocardial infarction, these are contraindication. Okay. They said here that the rate of endoscopic and operative intervention become lower than in the past because of the success of the neostigmine treatment. We said we usually give intravenous bolus, but sometimes it's available in a subcutaneous form, and it shows a fewer side effects. There are similar other agents than neostigmine. We can use, for example, pyridostigmine. I think if we ask an anesthesiologist, will help us. Pyridostigmine, which is a long-acting acetylcholinesterase inhibitor. We can give methyl naltrexone, and we can give, it's a peripheral acting opioid receptor antagonist. We know that the opioid receptor decreases the bowel motility, so it will increase the bowel motility. And we can give prokinetics such as metoclopramide and erythromycin. They shows a degree of successful in the treatment. If medical therapy failed, if pharmacological therapy failed, we go to colonic decompression. And actually, colonic decompression, it's colonoscopy to decompress the extremely dilated bowel. It's a second line after the failure of neostigmine, after the failure of medical treatment. We can proceed to colonoscopy with high success rate, about 95. Some studies about is it necessary to put the colonic decompression as a first line in the treatment of colonic obstruction and acute colonic soda obstruction, but they said that the treatment with neostigmine is a low cost. The safety, the efficacy of the neostigmine, and the cost and risk related to endoscopic decompression put it as a second line treatment. Also, we have here a risk in colonoscopy, risk for perforation, especially that these patients are typically hospitalized with comorbidities and didn't have bowel preparation, so risk for side effect is higher than usual patients. Repeated colonoscopy can be done if it's failed, here you see repeated colonoscopy may be required in 40 patients with high success rate. Remember here that patient requires sedation, and sedation we should avoid narcotics because they interfere with the colonic motility. Actually, the type of sedation can be relies on diazepine, benzodiazepine. Okay, important topic that when we decompress the colon, we should actually reach the descending colon. Sorry, the ascending colon, and we have to insert a rectal tube or colonic tube to give chance for the bowel to empty these gases, and this is cruciate and important when doing colonoscopy, decompressive colonoscopy for patient with pseudo obstruction. So we should reach the ascending colon, we shouldn't reach the cecum, and an intestinal, long intestinal tube should be inserted to stent the colon and to allow for continued post-procedure decompression. Some studies about does cecostomy helps us bringing cecostomy, either endoscopic cecostomy, we will see we can proceed for what we call it percutaneous endoscopic colostomy or CT guided colostomy to prevent or to help us in acute colonic obstruction. Okay, the utility of this approach is not well documented till now. About the surgical treatment, we failed colonic decompression, we proceed to surgical treatment. Please remember that surgical therapy here is the third line treatment. It's after failure of medical treatment, failure of pharmacological treatment, failure of colonic decompression, so we proceed to surgical therapy. And it can be, we can proceed to surgical treatment from the beginning if there is sign of ischemia, so we proceed for exploration as an emergency surgery. When to proceed for surgery, we said after failure of the previous, but it's also individualized according to each circumstances. Should be the timing of when to proceed is individualized, especially in the light of the mortality. The mortality rate is higher as we go in the intervention up, so it's less when we use medical, it's a little bit higher when we use neostigmine pharmacological, it's higher in colonic decompression and high in surgery, the mortality rate. So here they compare the mortality rate when we use pharmacological. Here, when we use pharmacological, it's about 7. When we use colonic decompression and surgeries, it reach up to 12. Of course, we are here talking about with no sign of strangulation. We said if there is sign of ischemia, it's reach up to 30%. Okay. They talk about in practice they like to delay surgical treatment as much as they can, even repeated colonoscopic decompression, repeated pharmacological intervention is preferred than proceeding for exploration. If we proceed for exploration, we have to check if there is perforation, if there is gangrene, if there is anatomical causes. So what we should do, should we do colectomies or bringing a stoma, just a ventilating stoma? So exploration to confirm if there is no compromised colon, no sign of ischemia, and then to decompress and ventilate through a colostomy. The rule of colectomy, doing colectomy under these circumstances. They mean these circumstances, no sign of ischemia is questionable. So what we should do is actually bringing a colostomy. If we have perforation and ischemia, we do resection and we bring an end stoma. Actually, the extent of resection, should we do right hemi, left hemi, total, subtotal, this depends on the operative finding and the clinical course. So if the patient is straightforward, please bring end stoma. Okay, we covered the most important topics in acute colonic soda obstruction or Golgi syndrome, and we proceed to volvulus. Okay, just before talking about volvulus, one single information I forget to mention it in acute colonic soda obstruction, that as you cannot see the risk associated with failed medical and pharmacological treatment. These include male gender, younger age, post-operative areas, and those which is associated with electrolyte abnormalities. Okay, let's move to volvulus. Volvulus, as you know, it is twisting or rotation in the axis of the lobe of the bowel. It can be counterclockwise or clockwise. Okay, okay. 15% of large bowel obstruction is due to volvulus. Actually, the common site is the sigmoid. This is maybe related to the anatomy. It's redundant with narrow mesentery, so it can be float. It can be floating. So sigmoid is the most common site, stand for about 60%, while cecum is the second most common site, and it's about 40%. The topics which we are going to discuss is the sigmoid valvulus, cecal valvulus, and gastric valvulus. Actually, today is Saturday, the day before the school, so the kids are playing and they are screaming loud. So, acute colonic volvulus, as we said, it's twisting. We are talking here in general about sigmoid and cecal valvulus, and we will review every item separately. Okay, what we are going to say here. We said acute colonic volvulus. Okay. Okay. Actually, when volvulus happens, this will lead to what we already discussed, closed loop obstruction. There will be proximal and distal part that is compressed, so it will lead to a closed loop obstruction, and this, if not treated or spontaneously resolved, will lead to ischemia and perforation. Okay, okay. We said the most common site is the sigmoid, 60%, and the cecum, 40%. Okay, the difference between the sigmoid and the cecum, it's actually in two main things. First of all, the sigmoid occurs for unknown reason in a counterclockwise fashion, whereas the cecal valvulus happens in a clockwise fashion. This is first. Second, sigmoid volvulus is more common in male who are above 70s, so an elderly patient, African American, diabetes, institutionalized, or have neuropathic or neuropsychotic comorbidities, while cecal valvulus typically comes in a young, more likely in female. The risk factor of volvulus in general, and particularly in sigmoid, is that the anatomy, the colon, the sigmoid is redundant with a relatively narrow mesentery. Other risk factors include constipation, colonic dysmotility disorder, and prior abdominal surgeries and previous volvulus. Okay, actually, the colonic volvulus, either it's sigmoid or cecal, it's endemic in some places and not that common. For example, in the United States, it's more common in areas that's called they called the valvulus belt on the map, the world map. It's like a belt. It's in Africa, Middle East, India, Brazil, South America. It may be related, they said this may be related to multifactors, including the diet, attitude. Actually, high altitude areas are more common, such as in Peru, as we will discuss in a few minutes. Okay, okay, what else we can as well? The symptoms, okay, it's abdominal distension, decreased bowel function, and obstipation, nausea, and abdominal pain. Okay, we said be careful if the ileocecal valve is competent, this can lead to closed loop obstruction. If incompetent ileocecal valve, the obstruction will progress in a retrograde fashion and will lead to secondary small bowel obstruction. Actually, the obstruction in the colon, but with incompetent valve, will lead to bowel obstruction, small bowel, and will lead to vomiting. Okay, we said ischemia and perforation can lead to sepsis. Okay, uh, actually, in the past, it was the diagnosis clinically plus X-rays. Now we depends more on the CT scan. Many cases are diagnosed intraoperatively at the time of exploration. These are the classic pictures of how valvulus can present in X-ray. Okay, again, this is the picture of sigmoid valvulus, how the classic picture comes. It's called the coffee bean or pent inner tube. This is the classic picture of how cecal valvulus present. A sign on X-ray you can find is the northern exposure sign. It's when the sigmoid is above the transverse colon. Okay, also a picture, one of the classic radiological manifestations for sigmoid volvulus is the paired peak sign. You can see here on water soil label contrast enemas. We give enemas. Actually, here is you can see the tapering when where the twisting happens. It's a paired peak sign. Okay, these are radiological. On CT you can see the swirl or whirl sign. Actually, you can see it here. To see this picture accurately, you should scroll up and down in a dynamic fashion to know to see it better. Okay, we said in the previous we rely on enemas and radiograph. Now CT scan is becoming more popular with high sensitivity and specificity. Okay. They said that the CT can also pick up ischemia, perforation, arterial occlusion, many air fluid, free peritoneal air, nematosis intestinalis, venous obstruction. These can also picked on CT and not picked on barium edema or X-rays. Okay. Even on the presence of CT scan is the preferred modality to diagnose volvulus. Many patients can be Some patients are not diagnosed until the time of exploration. And entirety explained here or mentioned here is what is called cecal pasculi. You can see this is the cecal pasculi. It's actually when the cecum is twisted and displaced upward anterior to the to the ascending colon. Here it's a rare entity, distinct from volvulus, no axial torsion. The caput of the cecum, is displaced anteriorly and folds over the ascending colon. Okay, with competent endocecal valve, this will lead to closed loop obstruction. Okay, even we can it can be demonstrated in cross-sectional imaging, but commonly it's an intraoperative finding. Um, okay, the treatment and evaluation for cecal pasculi is the same for cecal valvulus. And another entity also mentioned here is the mobile cecal syndrome. Mobile cecal syndrome is when there is a absence of the lateral peritoneal attachment. So the ascending colon and cecum is mobile. This will result in mobility of the cecum. Okay, okay. What to do in similar cases? We can proceed for laparoscopic cecopexy. Okay. They mentioned here just the outcome of cecopexy and that is conflicting. When to proceed for cecopexy doesn't matter for us at this level of explanation. Okay, they mentioned the concept pre-volvulus also. It's not supported and documented well, so we will not mention that. Just you can, if you are interested, you can check the pre-volvulus condition. So we talked about the mobile cecal syndrome, cecal pasculae, and in general imaging and clinical picture of sigmoid and cecal volvulus. Let's talk in detail about sigmoid volvulus. What's specific about sigmoid areas? As we said, it's common in what we call it the volvulus belt. It's more common in Asia, in India, in the Middle East. It may be associated with the high fiber diet used in these countries. Also in areas with high altitude, cause altitude, I hope the pronunciation is well, and such as in Peru and Bolivia. More common, as we said, in female and old ages. In contrast, the 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 sigmoid, the cecal volvulus in female and in younger ages. Um, okay, here they said that it's more common in those with laxative usage for chronic constipation. It's common in Ogilvy syndrome, in mentally retarded individual, Chagas disease, hypothyroidism, anticholinergic drugs, multiple sclerosis, scleroderma, and Parkinson disease. This we said that the anatomy play roles with the long mesentery and narrow root. Long sigmoid can play a role in sigmoid volvulus. Some of the predisposing factors are adhesion, diverticulitis, and peridiverticulitis. In the lecture of diverticulitis, we said the correct term is to call it peridiverticulitis. And redundant pelvic colon, long pelvic mesocolon, narrow attachment of the sigmoid colon. It's always for unknown cause anticlockwise, and to reach vascular obstruction should be require one and a half turn to cause vascular obstruction, which may lead to ischemia, gangrene, and perforation. Okay. Okay, the iliosigmoid knotting, I will show you a picture in the next few minutes. What does iliosigmoid knotting mean? It's different entity. The type of sigmoid volvulus can present as acute or recurrent, and this will give us the acute on chronic picture. Clinical features, these include pain initially in the left side and then all over, absolute constipation, obstipation, no gases nor stools, distension of the abdomen starting from the left iliac fossa, tympanic abdomen, and vomiting. Actually, vomiting means we have secondary bowel obstruction. Obstruction means we have incompetent ileocecal valve, which will lead me to dehydration, feature of peritonitis if we have perforation, hiccups, and if you like the classic information, if thyroid-like feel of the abdomen, this means volvulus sigmoid. The investigations, we said X-rays. We start with X-rays. We have the omega sign. Okay, the coffee bean sign, the pent inner tube on enemas, pent inner tube on X-ray, a bird beak sign, or the Aki of Spades, Spades. I'm not sure of the pronouncement. This is Imperium enemas. CT is more diagnostic and shows the what we call it, the whirl pattern or whirlpool pattern. Okay, the treatment, as we said initially, we start with NG tube and IV fluid, urine output measurement. We can add antibiotics, and an important rule here, the rectal tube or colonic tube that should be inserted if we reach successful detorsion. So we can use sigmoidoscope or proctoscope, depends on the degree, on the site of obstruction, to relieve this volvulus. Actually, we will talk that it is like a step ladder. We first start with proctoscope, sigmoidoscope. If that fail, we proceed to colectomy. Sometime we proceed to colectomy or laparotomy from the beginning if there is sign of strangulation. It's not like when treating Ogilvy syndrome or pseudo obstruction of the colon. It's a step ladder. We usually or mandatory proceed for surgery because of the high recurrence rate. We will see, but we are reviewing in general how we can treat it. If it is if it rated patient pus flatus and feces, so the distension will reduce. Okay, we will discuss this item. We can proceed to sigmoidopexy. If there is evidence of gangrene, we have to proceed for surgery. The surgery can be, why just I'm not concentrating on how we can detour it, because after a minute we will discuss the non-operative method of devolvulizing the sigmoid volvulus and you will understand. But in general, we start with decompression or devalvulization method, and then we proceed for surgery. The surgeries, just a rapid review, we have two main surgeries. Either we resect this is the volvulus part, this is the volvulus part, we resect it and we bring a proximal and distal. The proximal is for diverting the stool and the distal for mucus discharge. This operation calls, where is it? Paul Nicolai's operation. or we proceed for Hartmann surgery. This is Hartmann surgeries. We already review it. Proximal end colostomy, and the distal stump is closed. Of course, here primary resection and anastomosis is not advisable because we have contamination, we have anastomotic leak risk. These patients usually we said are elderly, so it's not. Okay, the non-operative method. This is, you will now understand. I know it was a little bit cloudy when we discussed the treatment. The non-operative method. First of all, we have evidence of sigmoid. We have radiological evidence of sigmoid valvulus without. It should be without peritonitis, perforation, and should be clinically stable, no sepsis, so we can proceed to detorsion using endoscopy, proctoscopy, sigmoidoscopy. It depends on the level of the obstruction. Be aware that this patient is high risk for perforation. This is emergency procedure. There is no bowel preparation, usually done in emergency setting, so high risk for perforation. Usually we put the patient on the left decubitus position without sedation. Proctoscope is usually tolerated without sedation. A rigid proctoscope is passed, and we individualize the place where torsion happens. It will looks like this. It's called the pinwheel appearance. This is where the limb of obstruction happens, and actually I practiced this before. When you do reduction, you will notice a significant amount of gas and particles, feces comes out, and this means a successful detorsion happened. So this is the valvulized mucosal appearance. You can see it here, how it looks like, and it's described as a pinwheel appearance. Okay, we said that there will be a dramatic decompression with efflux of colon continent. Okay, did we finish? The answer is no. We have to proceed with a tube. Of course, we have to check for signs of ischemia. If there is sign of ischemia, so we have to proceed for colectomy. Okay, we said here, if there is no sign of ischemia, we reach successful detorsion, so we have to proceed for transrectal decompression tube. I know that some of you will say it will not help. It will be blocked within few hours with this tool, but it will stent the volvulus part and will prevent early recurrence post procedure. So we advise to proceed routinely for transrectal decompression tube. Okay, here they say that usually they clogs with a stool, but to stent the previously volvulized segment, and so volvulus does not recur immediately. Okay, they just explain here how is it proctoscope, anoscope, sigmoidoscope. Actually, it depends on and they advise to do X-ray after inserting the tube because you may perforate, and also to look for free air, and also to look for the level of your tube. You see here the rectal tube is advancing. Okay, they said here an alternative for rigid proctoscope is a flexible sigmoidoscope. Okay, Also, the mortality rate is 3% mortality rate, and this is not associated with detortion itself. It's a reflection of the patient population. They are all multiple comorbidities. So, okay. The risk of recurrence is after first admission of sigmoid volvulus is about 70 up to 70%. Uh, so, what to do? I did decompression with a proctoscope or sigmoidoscope. I inserted rectal tube. So, is it enough? No, we usually proceed for surgery. But when, this is the question, is it in an emergency? After, immediately after detorsion, the or devalvulizing the part, or in a semi-elective. Semi-elective means within the same admission, or as an elective cases after discharging the patient and doing CT colonography and doing colonoscopy and doing bowel preparation. This should be individualized actually, and you should keep in mind that these are old patients with multiple comorbidities. So the answer, if you want a classic teaching information, a common teaching and practice, is to do it with a semi-elective during the same hospitalization. But that doesn't mean that you cannot proceed to elective operation. And this will give you time to do colonoscopy or to do CT colonography and to do bowel preparation. Okay, surgery for sigmoid volvulus, we said, we usually, it's not like the pseudocolon again, the treatment of pseudo obstruction, acute colon pseudo obstruction. We usually doesn't reach the surgical management. In volvulus, we usually proceed. The recurrence rate is about 70%. So, what is the option in surgery? And surgery for sigmoid volvulus, as we said, it's usually mandatory. We proceed for surgery after detorsion, after successful detortion, and we may proceed directly to surgery if there is evidence of ischemia or perforation. The mortality rate, as we said, in perforation and sign of ischemia is up to 40. Okay. Generally, the surgical options I divided to resectional and non-resectional type. Resectional in a form of sigmoidectomy, Hartmann, segmental, subtotal, and non-resectional in a form of sigmoidopexy, in a form of mesosigmoidopexy or mesosigmoidoplasty, we will see in a few minutes, and also in a form of percutaneous endoscopic colostomy, we will see in the next few minutes. The question is, can we proceed laparoscopically or we should go to open surgery? Actually, this depends on a specific patient circumstances, individualized, and expertise experience. But actually, in volvular surgery, even we have a reduction or devalvulization of the part which was twisted, the colon remain enlarged, and this may prevent the laparoscopic approach to be proceed completely. This is one. And two, actually, we do not need that extensive incision, midline incision. We just need a small lower midline incision, because in such elective and semi-elective surgeries, we do not need to do, for example, splenic flexure release. So the incision will be small and manipulation will be not that high. As you see here, in addition, the splenic flexure doesn't typically need to be released, so this may support the open approach over the laparoscopic approach. Commonly, intraoperative, we will see a fibrous or a fibrosis in the mesentery. This doesn't mean that this is the cause of the volvulus. Actually, this is the sequence of the volvulus. As you can see, it's not the causative factor of the volvulus, but it's the result of repeated volvulus. We will find a fibrosis along the peritoneum and mesentery. Okay. Okay. The most common operation performed is colectomy. Okay, colectomy. What else we can do? Okay, colectomy. Should we proceed for? Actually, Hartmann is considered colectomies, Hartmann procedures. Actually, sigmoidectomy with end-to-end anastomosis is colectomy. Sigmoidectomy with end-to-side anastomosis is colectomy. Subtotal colectomy is colectomy. So we have variety, but what we should keep in mind that we have volvulus. Frequently, we will see a perforation or a pending perforation or venous ischemia at the cecum. At these circumstances, we have to proceed to subtotal colectomy. If the cecal is affected or there is evidence of ischemia proximal to the site of obstruction, so we should proximal to the volvulized loop. If there is ischemia, we should proceed to subtotal colectomy. Okay, subtotal colectomy with end ileostomy, for example, with loop ileostomy, or I can proceed to ileocolic anastomosis. This depends on the surgeon intraoperatively and the status of the patient intraoperatively. Okay. What else we have to add? Okay. One of the recommendation intraoperative is to do resection without detortion the volvulized part, because this is theoretically associated with potassium release, bacterial release, and endotoxin release. So if you want to resect it as it is. If there is evidence of volvulus, of course. But sometimes it may be difficult, especially if the sigmoid is twisted around the mesentery. The mesentery will be thick and it's difficult to ligate or cut the mesentery without detortion or without untwisting the colon. But nowadays there are some energy devices that are capable for coming across this thick tissue. Okay, does oncological resection is required? Actually no, but it's preferable. As you see here, an oncological operation with nodal catch is not required under these circumstances, but it's usually or better to ligate the main mesenteric pedicle rather than to go near the colon and repeatedly cut the feeding vessel. Okay. Be careful of the left ureter. It will be in that part. Okay. We may proceed to procedures to decompress the colon, not devolvulize, but to decompress. We may open the colon and suction the content to decompress the colon. It will help us in the resection. Okay. After resection, once the resection is done, the question now is, should we restore the continuity, or in another way, should we do anastomosis or we proceed with stoma? Okay, and the answer here you can see here in emergency operation, the decision is individualized risk assessment and the clinical status of the patient. in semi-elective or elective operation for a previously distorted sigmoid volvulus, patient commonly have anastomosis created. So if we are proceeding in an elective or semi-elective, we usually do anastomosis. Some of you will say that actually we have sigmoid, either proximal or distal part will be severely dilated, so anastomosis will be not that easy. Yes, and for this we can proceed. Actually, we usually do by a circular stapler end-to-end anastomosis. Unfortunately, I haven't picture here, but you can imagine here in this picture, we proceed the stapler from here, and a metallic tissue will be here, and they are attached together, and end-to-end anastomosis. If the segment is severely dilated, sometimes it's difficult to do end-to-end. The anastomosis will be extremely large, and technically it's not accessible. So we can proceed, what I want to say that we can proceed to side to end Baker type. This, as you can see here, side to end when it's extremely dilated, called Baker type anastomosis. Of the non-resectional operation, these are mesosigmoidoplasty. You can see this is the mesosigmoidoplasty. I didn't see it in the practice. I just bring this picture for imagination. Mesosigmoidoplasty and sigmoidopexy. Yes, they are associated with high recurrence rate when we compare it to colectomies, segmental or subtotal. But it may be, of course, they carry a lower rate of morbidity and complication. Another option that can be used for volvulus is what we call the percutaneous endoscopic colostomy. Actually, you can see in this picture, it's like an endoscope, transanal, proceed to the sigmoid part or the valvulized part, and they do an opening in the bowel to the skin, and they do colostomy, so that the colostomy is fixed to the abdominal wall. It's type of sigmoidopexy. Okay, so it's called percutaneous endoscopic colostomy. Actually, the studies is still discovering the advantages and disadvantages of this procedure. We, of course, should keep in mind that it may be an option for a patient who have a high risk. When to reverse the stoma, it's not clear till now. It can be done at the time of reduction of proctoscopy or sigmoidoscopy, when detorsion is attempted. As we said, many complications associated with this procedures. It doesn't mean that it's minimally invasive, that it is without complication. The study is not clear about this approach till now. So we reviewed how to treat volvulus. We tried with medical treatment. We treat it as intestinal obstruction. Then we proceed to decompression, colonoscopic decompression. Then we proceed to surgery. We reviewed the surgeries that we can proceed in volvulus. Let us talk in details about cecal volvulus. And as we said, the cecum is the second most common site, about 30%. It's more common in a young, it's more common in female, present as intestinal obstruction. We discussed the issue termed cecal pasculi, and we said the treatment is like volvulus. Okay. You can remember the X-ray, the classic X-ray seen in volvulus, in cecal volvulus. I mean, we here it is. This is the cecal volvulus. Okay, let's come back. What's else about? It may be associated with malrotation. This is an interesting information that, sorry, cecal volvulus is the commonest cause of large bowel obstruction in pregnancy. We already see how the x-ray looks like. Okay. Actually, the treatment here is simple and less complicated when compared to sigmoid valvulus. It's resectional surgery. Um, um, Again, resection and anastomosis also is preferred. You can see here resection and anastomosis is the only treatment. Okay, it's not the only treatment, but it's the preferred treatment. Again, should we proceed for laparoscopic or open surgery? This depends on individualization of the case and the experience of the surgeon, but we should keep in mind that actually these are dilated, but actually these require a short incision in the abdomen. They require also incision to extract the dilated bowel. So we push toward the open approach till this time. Okay. Okay, as we said, here we proceed for surgery. We do not try reduction or colonoscopic reduction. We proceed for surgery. This is an emergency surgery, even in the absence of sign of sepsis or sign of perforation. We proceed for surgery and ileocolectomy or right hemicolectomy and anastomosis. The surgical approach is surgery. Okay. What else? We talked about laparoscopy and how we prefer. The most common operation performed to treat and prevent cecal volvulus is ileocolectomy with anastomosis. Right hemicolectomy, yes, we take part of the ileum and we do anastomosis. In some cases, we can bring stoma. If we have gangrenous part, if the patient is unstable, we can bring stoma. You can see here in high risk patient, we can proceed with ileostomy. The continuity of the bowel, as we said, anastomosis is usually performed. These are young patients, they are capable to tolerate the surgery, but in some cases, unstable patient, for example, we can proceed for stoma. We lift the discontinuity, they mean that we bring stoma, and we can proceed later to second look surgery. Okay, as we said, there are some non-resectional alternatives such as cecopexy, cecostomy, but they are associated with high recurrence rate. So we preferred resectional surgery in a form of right hemicolectomy, ileocolectomy, whatever. Okay, gastric volvulus. Yes, I know that it's not. It may be discussed in another lecture, but it's a rapid review. There are 2-3 simple information we have to remember about gastric volvulus. Actually, this is the upper GI tract, but it's extremely simple, and we will discuss it in a few minutes. Okay, and gastric volvulus is less common than sigmoid or cecal volvulus. It's a twisting of the stomach around its axis, and the lead point of fixation will be the cardia and pylorus. This depends on what type of gastric volvulus we have. We will see. Actually, you can see this picture. This is where volvulus can happen either around this line or this axis between the cardia and the pylorus, and torsion will happen, or this axis called the mesentericoaxial. Actually, this is more common. This type is more common in elderly, called the horizontal axis, and the mesentericoaxial is more common in children. These are the two, the organoaxial and the mesentericoaxial. This is actually more common ectopy in elderly patients. Okay, we said we have, apart from this classification regarding the axis, we have also idiopathic type, which is more common, about 60%, and secondary type or type 2, which is type 2 or secondary, which comes due to hiatal hernia or diaphragmatic eventration, adhesion, or pyloric obstruction. Okay, we said we reviewed these types. Okay, clinical feature. I think you can remember the Pochard triad, which consists of pain, epigastric pain, retching without vomiting. Actually, we have closed proximal or proximal obstruction, so no ability to vomiting. This is one of the classic questions in the exam. Vomiting present? The answer is no. So retching without vomiting and inability to pass the NG tube. Other classifications: acute or chronic. We said acute, chronic, recurrent, most common. We said organoaxial in elderly, mesentericoaxial in children. This is most common. Okay. Complication: these are perforation, gangrene, bleeding, gangrene of the stomach. Investigations: it's better to start with X-ray, put the NG tube, see the NG tube is passing the pylorus, reaching the stomach or not. Barium meal CT scan can be helpful. Treatment depends on there is ischemia or gangrene of the stomach or not. We can proceed for just gastricopexy by fixating the anterior wall of the stomach to the abdominal wall, or we can proceed to gastrojejunostomy, actually resection, partial gastrectomy, and proceeding for gastrojejunostomy. Gastrectomy if there is evidence of gangrene, of course, and of course treating the underlying cause if we have hiatal hernia or eventration. Some surgeries consist in bringing the transverse, I think the colon, whatever, the colon up, downward, displacing the colon downward by dividing the gastrocolic omentum. This is Tanner operation. Okay, this is the gastric volvulus. Okay, let's move. I think you remember we said idiosigmoid knotting, and it's extremely simple. The idiosigmoid knotting is one of the causes of intestinal obstruction. Okay, and to imagine what idiosigmoid knotting mean, you can see this picture. Let us do. It's actually wrapping the ileum around the sigmoid. So we have a pathology in the ileum and a pathology in the sigmoid, or compromised ileum and compromised sigmoid, and they call it double, I think, where double loop obstruction. So it's sometimes catastrophic in form of it's actually diagnosed as volvulus, but we are unable to devolvulize this part, and we have two parts of the intestine that are deceased. Okay, they are not common in the United States, but they are common in area where volvulus is common, in the volvulus belt. Okay, what we can add more? We said they are a double loop obstruction. They mean that obstruction in the sigmoid and obstruction in the cecum. When to actually we can do the diagnosis on imaging study, but frequently it is the diagnosis is made on the time of surgical exploration. Okay, when to suspect idiosigmoid knotting? Actually, it's when we have an imaging suggest volvulus, plus we have secondary bowel obstruction. Secondary bowel obstructions actually means incompetent ileocecal valve. We have colon obstruction, and that progress in a retrograde fashion to the small bowel. Plus, we said we have volvulus and imaging study, we have obstruction in the small bowel, plus we are not able to reduce the sigmoid volvulus. We made our diagnosis as a sigmoid volvulus. We tried to do decompression, colonic decompression, but we failed. This will rise the suspicious of iliosigmoid knotting. Of course, operation here is resectional, and preserving the continuity or bringing a stoma depend on the anatomy and the patient circumstances. Okay, this is the iliosigmoid thing. About the hernia as a cause of intestinal obstruction, we said that we briefly will discuss the hernia as a cause. Okay, and as we said, hernia as a cause of intestinal obstruction was the most common cause, then adhesion replaced hernia. This depends on developed country and the literature you review. But if we are talking about large bowel, so it's rare cause of large bowel obstruction. Okay, hernia in a different form, either external hernia or internal hernia. External hernia such as femoral, inguinal, umbilical, spigelian, lumbar, diaphragmatic hernia. You can review a lecture in this series about hernia. We discussed the external hernia or the abdominal wall hernia in details. Internal hernia also a rare cause of intestinal obstruction. You can see this diaphragm. Actually, the internal hernia is divided to acquired or congenital hernia. Acquired Peterson hernia, it's a type of post Rowan-Weiss bypass. Peterson hernia, para-anastomosis hernia near the anastomosis. Parastomal hernia is a part of acquired internal hernia, post-trauma hernia, post-inflammatory, and post-surgery, and specifically bypass. Congenital hernia of these can be the transmesenteric, the broad ligament hernia, transflaciform hernia, transmesocolic, transomental hernia. These are intraperitoneal, while retroperitoneal through the foramen of Winslow, through the pericecal, through the intersigmoid and pelvic and paravesical hernia. These all are type of hernia. Actually, it's even on radiological study hard to diagnose, and sometimes they are explored at the time of surgery. You can see this picture. Where is the foramen of Winslow hernia? Where is the paraduodenal, which is the most common type of internal hernia? Paraduodenal hernia. Where is the transmesenteric? Here is the mesentery and transmesenteric hernia. Transomental hernia over here. It's part of the bowel that penetrate the omentum, the mesentery. Sigmoid hernia and mesocolon hernia, mesocolic hernia, and of course the paravesical or pelvic hernia. What we can add, except of the classification or the types according to the site, these were what is written just over here. Okay. Gastrojejunostomy hernia causes Stammer's hernia. Okay, other we just discussed, and the features, they are features of intestinal obstruction. They actually associated with adhesion, can present as acute, subacute, or recurrent, and diagnosed usually at the time of surgery, but some studies such as CT or barium enemas can help us. Treatment, actually, these are release of the adhesion, resection of hernia, and depends on the viability of the bowel. We proceed for resection or anastomosis or just reduction. The next entities are discussed well and explained well in the pediatric surgery lecture. In this series, you can refer to this lecture. They are discussed well, but they are a recognized cause of intestinal obstruction. Of these are the duodenal atresia in the pediatric age group, duodenal atresia, you can remember the double bubble sign, the classification. We are not going to focus on these. Okay, they are the most common cause of duodenal obstruction below 1 month. Malrotation above 1 month. The treatment is duodenostomy or duodenojejunectomy. Okay, intussusception also. Intussusception can present in adults and can present in children. Actually, in adult we do not have the typical picture of Carangelli stool and that we know. Actually, these present usually between 3 months and 3 years, and other different between adult and pediatric, that adult usually have a leading point. Okay, most common to be malignant, but also it could be benign, and we use reduction. Of course, ultrasound is accurate. We have the donut target sign. We use reduction either air contrast enema or barium enema with certain parameters. We shouldn't proceed these parameters because bruxiscope perforation can produce. We can use these twice, try twice for 1 hour, and the indication for surgery, it's after the third recurrence, or if we have sign of strangulation or perforation such as free air. Okay, this is how intussusceptions looks like. Intussusceptions, we said intussusceptions as a cause of large bowel obstruction, it is rare. It's near 1% of mechanical bowel obstruction. And lesion can be found, or leading point can be found in up to 80% of the cases. We said the classic triad of symptoms that is seen in pediatric intussusception is absent in adults. The most common cause of large bowel intussusception is malignancy in about 70%, but benign causes can present, such as adenomatous polyps, gist tumor, diverticular disease, villus adenoma of the appendix. These are our recognized causes. Also, one information we want to add. Okay, that in concern have been raised that endoscopic reduction of an intussusception could theoretically result in dissemination of malignant cell or cancer. We said that in adult, it's usually cancer. We said that intussusception in pediatric, we usually try to do pneumatic reduction or contrast reduction. In adult, no, we proceed for surgery, and usually we do not release the obstruction because theoretically these are malignant tumor, and with reduction of the intussusception or with attempt to pneumatic to reduce them by air contrast or pneumatic reduction, this will lead to widespread of the toxic material, and so it's preferred to do resection without reduction. This is what is meant here. And we have low threshold for surgical operation. Okay, intestinal atresia also discussed well in the pediatric surgery. Of what we can say, just remember that intestinal atresia is usually a result of intrauterine vascular event, intrauterine ischemia. It's while the baby inside the mother, associated with polyhydramnios, usually in the jejunum. I remember it can be multiple, and mainly in the jejunum, multiple types of these, this fibrous atresia or mucosal atresia. Okay, the multiple atresia. Malrotation also is discussed well. We have the Ladd's band, which is meconium ileus, is also one of the causes of intestinal obstruction, and we discuss the surgeries that can be done for meconium ileus. Infection as a cause of intestinal obstruction, we can remember tuberculosis. We repeated it multiple times. Mycobacterium tuberculosis can lead to stenosis and even obstruction. Also, actinomyosis can lead to abscesses, multiple abscesses, and lead to extrinsic compression of the colon. And the treatment, either antibiotic or abscess drainage, internal drainage, or laparotomy, or resection and anastomosis, or resection and stoma. This is individualized. Other infectious causes is schistosomias and helminthic infection, worms. We said roundworms, endometriosis, and gynecological condition that cause one of the gynecological conditions that can cause intestinal obstruction is endometriosis. Yes, it's common in female, but it is less common as a cause of bowel obstruction. It causes stenosis secondary to serosal infiltration, usually in the rectosigmoid region. Okay, okay. Now we come to the last part of this lecture, and I know that we reviewed and we talked about the malignant, how to deal with malignant large bowel obstruction in a brief. If you remember at the beginning of surgery, we had the picture here. I hope it's something over here. No, not this. No, it's up a little bit. Is it this? Yeah, you can see here the treatment of large bowel obstruction. These are similar to how we deal with malignant right-sided colonic obstruction. For example, we proceed for resection and iliotransverse anastomosis. Sigmoid is at Hartmann, and we reviewed how Hartmann and distal and rectum. We said any obstructing lesion in the rectum, we proceed for lobe colostomy. This is fine. Now we will focus a little bit on how we deal with malignant large bowel obstruction as a cause of intestinal obstruction. In brief also, it will take a few minutes and we will reach the end of this lecture. Malignant large bowel obstruction means we have cancer and causes large bowel obstruction. These are about 20% of patients with colorectal cancer will present as malignant large bowel obstruction, which would increase the morbidity and mortality to about fivefold higher. Okay. Okay, actually, these present with perforation, and so it carries a high risk for sepsis and ischemia. What to do? What type of surgery to do? This will depend. The clinical decision depends on the patient medical comorbidities, the history, after history taking, the physical exam, presence of sepsis, tumor location, right or left, this is important, and radiological investigations. So if perforation, if we have malignant large bowel obstruction and we have perforation, this is about 10%, 12% of the cases of colon cancer that present with large bowel obstruction will present as perforation. These are 10%. Perforation can happens either in the primary site of the tumor or proximal to the tumor due to ischemia and dilatation, and we discussed that the cecum is the most common site. It's called, when perforation in the cecum happens, called diastatic perforation. Okay. These patients who present with perforation rapidly progress to septic shock and multi-organ failure. We said we have 2 points for perforation, either the tumor point or the mass point or proximal to the obstruction. Okay. In some circumstances, we may proceed to damage control surgery principles when the patient is hemodynamically unstable. For example, he is in shock, the patient is in shock, severe metabolic acidosis. What does damage control surgery means? That means that limit the initial intervention. We just do wash out of the abdomen. We place a drain with possible defunctioning ostomy. We bring stoma and leaving the abdomen open, even with a plan for definitive resection when the patient is stable. So we can proceed to damage control surgery, just bringing stoma, put a drain, wash, and even do not close the abdomen. Okay, if the patient is hemodynamically stable, then the surgical procedure can address both the obstructing tumor and the proximal perforation. So it's not just where the tumor is, and it's also if there is proximal dilatation, if there is proximal perforation, if there is proximal to the site of the tumor ischemia. Okay, if we have, for example, right-sided tumor with perforation, so it's classic to proceed for oncological if we can. If the patient is hemodynamically stable, we can proceed for right hemicolectomy with ileocolic anastomosis. Okay, of course, this is an emergency surgery, so the increased risk of anastomotic leak when we compare it to elective surgery. Right hemicolectomy with ileostomy may be the safest approach in situation as to avoid the patient. We can bring stoma, they mean right hemicolectomy either with a primary anastomosis, or we can bring proximal stoma, proximal ileostomy. Okay. A left-sided tumor, always when there is a left side tumor, we said check the viability of the proximal bowel. We may proceed to subtotal colectomy, or we may just bring an end colostomy. Okay, here in a situation where is left side obstruction with proximal colon perforation, or concern for viability, we can proceed to total abdominal colectomy in cases of left-sided tumor and perforation in the proximal part. While if there is no perforation, we can proceed to end colostomy alone. Right-sided obstructed tumor, right-sided colon tumor obstruction means from cecum to the distal transverse colon. Here, usually the classic teaching is to proceed for right hemicolectomy with anastomosis. The leak risk is low, so we can proceed to right hemicolectomy. Okay, actually the right colon has wide diameter and it's usually liquid continent, so obstruction is less than the left side. Right side cancers still account to about 40% of causes of malignant left large bowel obstruction, while the left-sided large bowel obstruction, as we said, on the right side colonic tumor, we can proceed to resection and anastomosis. This is traditionally undertaken for the right side tumor because we have a low risk for anastomotic complication. Okay, what else we can add? Okay, the anastomotic leak rate is 14. This is higher than elective surgery, but it's lower than for left-sided colectomy, left-sided tumor. While most patients will do well with resection and anastomosis, there is some surgeons that prefer to go for resection with stoma. Actually, loop ileostomy, sorry. This is actually the surgeon intraoperative decision. Okay, this depends on the blood supply and the tissue quality. So, the conclusion Right side, please. Right hemicolectomy, ileocolic anastomosis. No need for ileocolic anastomosis. No need for stoma. You can proceed for stoma. It's your decision. The left side is a little bit complicated. Actually, in the past or in the past 30 years, the left-sided colonic tumor was performed in three stages. First, we do first stage, we just bring stoma. Second stage, we resect the tumor, and third stage, we do anastomosis. You can see here that creation of a loop colostomy, if we have malignant left-sided colon tumor, we proceed for loop colostomy. This is the first stage, and the second stage is the tumor resection, and the third stage is closure of the stoma. Actually, nowadays, no, this we do not support this three stage. We can proceed to colostomy with resection and later on closure, and the outcome is similar. Sorry, the outcome is similar. Whether in the index on the first surgery to resect the tumor or to leave it for second stage, we have the studies shows equivalent outcome between patient undergoing defunctioning colostomy alone or primary tumor resection. This is an important question, by the way. Okay, we said resection, we do loop colostomy with primer resection, no difference. Okay, we said no difference on the mortality, morbidity. Okay, what else we can add? So, to be more clear, sorry, to be more clear, for left-sided, we proceed to the traditional known for us or the Hartmann procedure. The Hartmann procedure consists of, it's because the leak rate in the left in the left side anastomosis is higher, and it's more devastating, more complication associated with leak in the left sided. Actually, we are talking here in the pelvis. So what we do, it's Hartmann procedure. What does Hartmann procedure mean? It's resecting the obstructing mass, it's stapling of the distal segment, and creation of an end colostomy. This is the most acceptable procedure among the surgeons. Okay, here they discuss if we are going, the system can be assessed via, I'm sorry, we actually, the question here, can we proceed in the emergency surgery for anastomosis in the left colon? Yes, it's not preferred, it's individualized, it depends on the patient stability, it depends on the surgeon decision. But here you have to remember that the colon is dilated. We have a problem in creation the end-to-end anastomosis. We have an unprepared, full of stool colon. These they deal with these problems with, for example, lavage. Here we have, they just review how we can do what they call it an on-table lavage, OTL lavage of the colon. This is the on-table lavage of the colon. They actually intubate the appendix stump and they do lavage. This is if you are thinking of stoma or of anastomosis intraop, or simply decompression alone. Either decompression alone, for example, you can see in this picture, they put a tube through an enterotomy and they decompress the fecally loaded colon. And multiple studies compares what is best to do, decompression alone or on table lavage. The big advantages, for example, that decompression it takes 13 minutes while on table lavage takes 31 minutes. There is no significant difference in overall mortality between the two groups. This is if we are thinking of anastomosis. We said left side we proceed for Hartmann, left side in the past they proceed for a three stage. First stage just bringing stoma, third stage resect the tumor, third stage they close. Hartmann, we resect the tumor, we resect the tumor, we bring stoma, and later on we close it. No, it's not contraindicated to do anastomosis. Yes, the risk of leak is higher, the complication of leak is higher, but if we are thinking of anastomosis, we have many challenges. Of these challenges is the fecally impacted stool. We see how we already discussed how we can deal with them, or the dilated the fecally loaded bowel and the extremely dilated bowel. Okay, another question. What is preferred or when to do segmental colectomy or total colectomy? I know that most of you can answer this question because we already discussed why we can proceed to subtotal colectomy if we have, for example, distal or left sided colonic mass and we have ischemia or perforation or pending perforation in the cecum, so we can proceed to sigmoid to subtotal colectomy. Actually, here it's a nice definition. A nice definition: extended colectomy, whether it is subtotal. Subtotal means we have iliosigmoid anastomosis, while total colectomy we have iliorectal anastomosis. They compare between extended colectomy, either subtotal colectomy or total colectomy, with segmental colectomy when they consider that segmental colectomy should come with a stoma. And so when proceeding for extended colectomy with anastomosis, we do not need for stoma. They compare the what is better to proceed for total colectomy or or subtotal colectomy or segmental colectomy regarding the that we can avoid stoma creation in patient who undergo segmental colectomy. Okay, these studies just they are reviewing what is better to proceed. Is it segmental or extended colectomies? Actually, I cannot deliver an important information for you because these are studies. Another another way to treat malignant obstructing large bowel tumor is the self-expanding metallic stent, and they are now becoming more popular, more acceptable among surgeons because they avoid the anastomosis at an emergency setting, they avoid colostomies, they give us time to proceed for elective surgery, so they are sometimes called a bridge to a bridging surgery, a bridging procedure for definitive surgery. You can see when to do self-expanding metallic stent. Actually, it depends on the patient and the surgeon and the availability of similar technique, and also if the patient is high risk or beyond surgery. If the patient have unresectable tumor, we can proceed for the stent. Here you can see the stent. This is how they inserted the stent in the colon. The stent can come in a different type, covered, uncovered, and we can compare between them. We said a clear indication for proceeding for a stent doesn't exist, but we can say that these are on availability of the stent, on if the patient is extremely ill, beyond surgery, we can proceed for stenting. Here you can see the classic indication is It is to palliate obstructive symptom for unresectable tumor or in patient who is too ill for surgical resection. Another important indication that it could be a bridging surgery. Patient is have resectable tumor and and come as an emergency surgery, or we doesn't we need more time to full investigate the patient, we can bridge it with a stent. Okay, here you can see the stent as we said here. Okay, here you can see the bridging to subsequent elective or semi-elective surgery. Just I want to mention that historically high rate of stoma formation and morbidity associated with emergency resection. This is already we discussed it. The surgeon now prefers stenting because they avoid stoma formation in the emergency setting. What I need to add is about the dissemination of tumor. We will discuss it. Okay, you can see here the intestinal obstruction. Here we have also small bowel obstruction. It's large bowel obstruction that progressed to secondary small bowel obstruction, and you can see here it's relieved after inserting the stent. Can you figure out where is the stent is? Yes, it's here. Okay. Here what I want to mention, that concern raised about the possibility of dissemination of tumor cells while stenting, especially in cases complicated by iatrogenic perforation. One of the complications you can see here, this is a stent, and here we have gas lock use. This is usually perforation. Okay. Here's the indication. We said that it can be a bridging to elective or to elective surgery compared to emergency surgery. Others here they just discuss and compare. Is it better to proceed with stenting, and they compare to the traditional surgery. Okay, actually here they just discuss the type of stent we have, covered or uncovered stents. I think these are the interest of the colonoscopist or gastroenterologist. They said, for example, uncovered stent, uncovered stent. These are the main two types, covered or uncovered. Uncovered stent were traditionally associated with increased risk of occlusion, so due to the growth of the tumor, while covered stent were thought to inhibit the rate of growth, the tumor growth. Okay. What's else here? They said that the risk of perforation and bleeding is the same between uncovered and covered stent. Uncovered stent is associated with low risk for tumor growth, while and decreased risk for stent migration. Okay, and uncovered stent is associated with lower need for stent reinsertion. Actually, I write them over here. It's a comparison between covered and uncovered. For example, in covered stent, the occlusion rate is higher. The tumor growth, it inhibits the tumor growth. The bleeding and perforation is the same. Low risk for perforation in a low risk for growth of the tumor in uncovered stent, and low risk for reinsertion in the uncovered stent. I know that you get, but you can. I think you can check this information in a better literature. I don't think that this is the best literature where to view the differences between covered and uncovered stent. Why? Because we just know the parameter between covered and uncovered stent. Why this is in this lecture is not the best the best place to review this parameter, because in some places, or in some places in this paragraph, they actually said something and says the opposite on the other side. So I'm not sure that it's the best way to study covered and uncovered stent and to compare between them, but we have to know what the parameter is. It's the migration, the tumor growth, the bleeding, the perforation, the risk of reinsertion. I hope you can see it in another literature. Unresectable diseases, we said, of the malignant large bowel obstruction, about 10 to 15% are unresectable at the time of presentation due to tumor infiltration or metastatic disease. They are unresectable. Okay. If there is no evidence of ischemia or perforation, we can proceed to either diverting stoma or self-expanding metallic stent. It's a palliative surgery. If there is ischemia, we proceed, and intraoperative, we decide to resect, damage control surgery, etc. Okay, we discussed the malignant large bowel obstruction as a cause of large bowel obstruction or as a cause of intestinal obstruction. There are some other malignancies that can cause large bowel obstruction, but they are not related to the colorectal cancer. Of these are the ovarian, the gastric, pancreatic cancer, bladder cancer. They are responsible for large bowel obstruction, but sometimes either due to the intraluminal obstruction if there is invasion, intramural blockage, or extrinsic compression. Okay, the management actually it depends on the clinical presentation and disease extent. Actually, we proceed as the simplest operation to do defunctioning stoma if we have, for example, ovarian cancer that is compressing the colon or doing invasion to the distal rectum. We bring a defunctioning stoma. Lymphoma is a recognized rare cause for large bowel obstruction, and lymphoma of the colon usually is treated with resection with or without anastomosis. This is the classic teaching information. Can we proceed with lymphoma to defunctioning stoma or stenting or chemoradiation? If time permit, no problem in similar technique. For example, treating the patient with lymphoma and presenting with partial large bowel obstruction, we can proceed for chemoradiation first, or stenting, or defunctioning stoma. The classic teaching is the large bowel lymphoma treated with resection and with or without anastomosis. Okay, thank you. We reached the end of this lecture. These are the literatures I get my information from. I know that some part of this lecture, especially the covered and uncovered stent, is not. I didn't deliver the information very nice. I told you because they are not explained well in this literature. I hope you can focus on this topic in another literature. I'm Dr. Jihad. I'm a colorectal surgery fellow, general surgery specialist, member of Real College of Surgeon. This is my number. I hope you can feed me back about the lecture. The last thing I want to say, and I will mention it at the beginning of the next lecture, that some of the feedback I received that these are a long lecture, and my answer is These lectures are not designed for those who are preparing to their exams within 1 week or 1 month. These are designed for those who are looking for the information and preparing uh, 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 for their exams in a long term. Thank you. Bye bye.